Hello, everybody, and welcome back to MooseMed. Today we're going to be covering all things Neuro Week 3. All right, so this slide is laying the foundation for basically every orbital anatomy and clinical question you'll get. The orbit is best understood by thinking in terms of its walls and the apex because of how pathology and exam questions are organized. So starting with the roof, this is going to be formed by the frontal bone. And clinically, this matters because the frontal bone separates the orbit from the anterior cranial fossa. So trauma here raises concern for communication with the brain or involvement of the frontal sinus. Moving to the medial wall, this is primarily formed by the ethmoid bone along with the lacrimal bone. The ethmoid portion is extremely thin, which makes it a major weak point. So this is high yield because infections from the ethmoid sinus can easily spread into the orbit, leading to an eye infection. So the lacrimal bone is in this region houses the lacrimal sac, which is involved with tear drainage into the nasal cavity. Next, the floor of the orbit is formed mainly by the maxillary bone, and this is the classic site of what's called a blowout fracture. Because the floor sits over the maxillary sinus and is relatively thin, increased pressure from trauma can cause it to fracture downward, allowing orbital contents to herniate into the sinus. So this often traps the inferior rectus muscle, leading to an inability to look upward and resulting in diplopia or double vision. The lateral wall, in contrast, is strong and protective, formed by the zygomatic bone and the greater wing of the sphenoid. Because of its strength, it's less commonly fractured and serves as a protective barrier against lateral trauma. The sphenoid bone also contributes critically to the apex of the orbit via its lesser wing. The apex is a major high-yield region because it serves as the entry and exit point for key neurovascular structures. The optic nerve, also known as cranial nerve 12, or 2, sorry, not 12. 12 is hypoglossal, and the ophthalmic artery pass through the optic canal here. So just adjacent to this is the superior orbital fissure, which transmits cranial nerves 3, 4, V1, and 6. These control most eye movements and sensation to the orbit, so damage to the apex can therefore provide or produce a combination of vision loss, ophthalmoplegia, and sensory deficits. Which is referred to as orbital apex syndrome. So finally, the palatine bone contributes a very small posterior portion to the orbital floor. It's minor, but it's still testable when identifying all bones from the orbit. So the key takeaway to keep in mind here is that medial wall is the thinnest and most susceptible to infection spread. The floor is most likely to fracture and trauma, leading to the inferior rectus entrapment. And the apex is where the critical nerves and vessels pass. So injuries there cause widespread deficits. Okay, and here we have that close-up on that clinical correlation of a blowout fracture. So once again, it's just force applied to the orbit, causing a fracture of those thin walls that we mentioned, which would be that medial wall and the floor. And the floor is the more common of the two. And like I said, breaking that can cause all your orbital components to basically sink into that maxillary sinus. So this slide is all about the eyelid layers. Okay, so starting from superficial to deep, the first layer is the skin, which is extremely thin compared to the rest of the body. That thinness is why even small amounts of fluid or blood become very visible in the eyelid. Right under that is loose connective tissue, abbreviated CT for connective tissue. This layer is continuous with layer 4 of the scalp, which is that loose areolar layer, meaning fluid-like blood or edema can track directly into those eyelids. That's why patients with head trauma often present with periorbital ecchymosis, what people call raccoon eyes. Even if the injury wasn't directly to the eye itself, it could present that way. The key idea here is that this layer acts like a potential space where fluid accumulates easily. So next is the muscular layer, which is primarily made up of orbicularis oculi muscle, innervated by cranial nerve 7, the facial nerve. The muscle is responsible for closing the eye, so if cranial nerve 7 is damaged, patients can't close their eyelid properly. Clinically, that leads to exposure of the cornea and potential damage. Also associated with this region, although deeper, is levator palpebrae superioris muscle, which elevates the eyelid and is innervated by cranial nerve 3, the ocular motor nerve. So lesions there cause ptosis or drooping of the eyelid. Moving deeper, the tarsal plate is a dense connective tissue structure that provides structural support to the eyelid, basically giving its shape and rigidity to the eyelid. So embedded within the tarsal plate are what are called tarsal glands, okay, which secrete an oily layer that prevents tear evaporation. Dysfunction or blockage of these glands can lead to a chalazion, which is a painless eyelid swelling. Finally, the deepest layer is the palpebral conjunctiva, which is a mucous membrane that lines the inner surface of the eyelid and reflects onto the eyeball as the bulbar conjunctiva. This layer is important for lubrication and protection of the eye surfaces. Inflammation here leads to conjunctivitis, which is extremely common clinically. It's just pink eye. So the big takeaways are that loose connective tissue layer allows fluid to spread easily into the eyelid. The muscular layer is critical for the eye closure and opening via cranial nerve 7 and 3 respectively. The tarsal plate provides the structural integrity and houses glands that are important for stability, and the conjunctiva serves as a protective and lubricating inner lining. All right, so now we just have a slide that is focusing on those muscles that control eyelid movement. And so we're going to be starting with orbicularis oculi. So this muscle, again, is responsible for the closing of those eyelids and is innervated by cranial nerve 7, which is the facial nerve. Functionally, this is your blinking and forceful eye closure muscle. If this muscle is paralyzed, like a facial nerve lesion such as Bell's palsy, the patient cannot close their eye on the affected side. Clinically, this leads to exposure of the cornea, dryness, and an increased risk of corneal damage or ulceration. You'll also often see associated facial droop because cranial nerve 7 innervates muscles of facial expression. But the key eyelid finding is that inability to close the eye. In contrast, opening the eyelid is controlled by levator palpebrae superioris, or LPS, which is innervated by cranial nerve 3, the ocular motor nerve. This is skeletal muscle classified as GSE, which again stands for general somatic efferent, meaning that it innervates voluntary skeletal muscle that is not derived from those pharyngeal arches that we talked about in weeks 1 and 2 of Neuro. Anatomically, the tendon of this muscle passes through the orbital septum and inserts onto the upper eyelid, allowing it to elevate the lid. So, if cranial nerve 3 is damaged, this muscle loses function, resulting in ptosis, which is drooping of the upper eyelid, and this is often seen along with cranial nerve 3 findings like that down and out eye due to the unopposed extraocular muscle action. There is also an additional layer of control provided by the superior tarsal muscle, sometimes called Mueller's muscle, which provides supportive tone to help keep the eyelid open. We'll get into that a little bit more later, but this muscle is not under voluntary control like LPS is, and is instead innervated by a sympathetic nervous system. And because of that, disruption of the sympathetic nervous system, such as something called Horner's syndrome, which we'll get into later, results in a mild ptosis. Not as severe as full cranial nerve 3 lesion, because the LPS is still functioning, but it's noticeable. The key distinction to lock in is that closing the eyes, cranial nerve 7, opening the eyes, primarily cranial nerve 3, and sympathetic input provides additional support to keep that eyelid elevated. So different lesions produce those very distinct clinical presentations. Okay, so this is walking through what's called the lacrimal apparatus, which is basically how tears are produced, distributed, and drained. And this is very testable because it follows a very clean flow. So tears are produced by the lacrimal gland, which sits in that superior-lateral part of the orbit, meaning the upper and towards your temporal side of your face. From there, the tears are secreted onto the surface of the eye and serve two major functions. They lubricate the eye to reduce friction during blinking, and they have antimicrobial properties, helping protect against infections. Once produced, the key concept is that tears move across the eye from lateral to medial, meaning from the outside toward the nose, driven by blinking and the contour of the eyelids. This is constant movement that creates a steady flow system rather than an intermittent drainage. So as tears reach the medial corner of the eye, they collect in a small pooling area known as the lacrimal lake, which is associated with the plica semilunaris, a fold of conjunctiva that helps guide fluid into this space. So from there, tears enter the lacrimal puncta, which are small openings on the superior and inferior eye, then pass into the lacrimal caniculi, which are small channels that carry fluid into the lacrimal sac, and then finally the lacrimal sac then drains into the nasolacrimal duct, which ultimately empties into the nasal cavity, specifically the inferior meatus. This is why when you cry, your nose also starts to run, because the tears are literally being shunted into the nasal passage. So the key high-yield takeaway is the directionality of this flow. So lateral to medial, and the stepwise drainage pathway from the lacrimal gland to the eye surface to the puncta, to the caniculi, to the lacrimal sac, to the nasolacrimal duct, and then eventually to the nasal cavity. So blockages anywhere along this pathway, especially in the nasolacrimal duct, can lead to excessive tearing or epiphoria because tears cannot drain properly. All right, so this slide is just organizing the eye into 3 tunics or layers. And this is the core framework you want solid because a lot of the physiology and pathology maps onto these layers. So starting out with the fibrous tunic, which is the outermost layer. Okay, this includes the sclera and the cornea. The sclera is the dense connective tissue that forms the white of the eye, and its main roles are to maintain the shape of the globe and serve as an attachment point for those extraocular muscles. Posteriorly, the sclera thickens and provides the structural support where the optic nerve, also known as cranial nerve 2, exits the eye. The cornea, in contrast, is specialized for vision. It is avascular, meaning it has no blood vessels, and is kept relatively dehydrated to maintain transparency. Its convex shape is critical because it bends or refracts incoming light, making it one of those main contributions to focusing light onto the retina. Moving inward, the vascular tunic includes the iris, the ciliary body, and the choroid. And this layer is composed of loose connective tissue and is highly vascularized, meaning it has rich blood supply that nourishes much of the eye. The iris contains melanocytes, which are pigment-producing cells that absorb excess light to prevent scattering, and it also contains smooth muscles control pupil size. So the ciliary body also contains smooth muscle, which is involved in accommodation, meaning adjusting the shape of the lens to focus on near versus far objects. The choroid is primarily responsible for supplying blood to the outer layers of the retina. And then finally, the innermost layer is the neural tunic, which involves the retina and is continuous with the optic nerve. This is where light actually gets detected and is converted into neural signals. The cell bodies of neurons that contribute to cranial nerve 2 are located within the retina, and these neural elements extend only as far anteriorly as what is called the ora serrata, which marks the boundary between the photosensitive and the non-photosensitive regions. Within the retina, the fovea centralis is the region where we want light to focus on because it provides the highest visual acuity due to its high density of photoreceptors, particularly cones. In contrast, the blind spot, or the optic disc, is where the optic nerve exits the eye and contains no photoreceptors, so light hitting this region cannot be detected. The key takeaway is that the fibrous tunic provides structure and light refraction, the vascular tunic provides blood supply and controls light entry and lens shape, and the neural tunic is responsible for detecting and processing that visual information. All right, so this slide is tying together the lens and the internal compartments of the eye, and this is where physiology starts to matter a lot. So the lens is responsible for focusing light, and although it's described here as shaped like a ball, functionally it changes curvature to allow for accommodation. So this just means adjusting focus for near versus far vision. The key concept is that the lens itself is passive. It doesn't actively contract. We have muscles to do that, which are the ciliary muscle, and that's what actually drives this change. So when the ciliary muscle contracts, it reduces tension on zonular fibers, which allow the lens to become more rounded, which is better for near vision. Okay, when ciliary muscle relaxes, the zonular fibers pull the lens flatter, which is better for distance vision. So the muscle is doing the work and the lens is just responding to those mechanical forces. Now, shifting to chambers of the eye, the anterior and posterior chambers are both filled with what's called aqueous humor. And this is a clear fluid that functions similarly to plasma but has less proteins and is constantly produced and recycled. The anterior chamber is the space where the cornea and the iris sit, so it's anterior or in front of the lens. And the posterior chamber is smaller and lies between the iris and the lens. Aqueous humor is produced by the ciliary body, and it flows from the posterior chamber through the pupil into the anterior chamber, and then drains out through structures at the iridocorneal angle. That's less important. That's just more to build the full picture. So this content flow is critical because it provides oxygen and nutrients to avascular structures like the cornea and the lens, which don't have their own blood supply. If this drainage pathway is blocked, pressure starts to build up in the eye, leading to what's called glaucoma, which is a major clinical condition tied directly to the system. So finally, the vitreous chamber is a large space behind the lens filled with what's called vitreous humor. And unlike aqueous humor, this is a gel-like substance rich in hyaluronic acid, my gosh, and you're essentially born with all of it. So you don't continuously replace it. Its main roles are structural, and it helps maintain the shape of the globe and keep the retina pressed against the back of the eye, which is critical for preventing retinal detachment. The key distinction to lock in here is that the lens changes shapes passively in response to the ciliary muscle and thus actively accommodates for near or far sight. So aqueous humor, again, is that dynamic and involved nutrient delivery and pressure regulation in the anterior and posterior chambers. And the vitreous humor is a stable gel-like substance that supports the structure of the eye and stabilizes the retina. And now, like always, we're just doing our deep dive into the topics we just talked about. So this is just going to be working through this flow of aqueous humor. So this is one of those pathways I really recommend just knowing cold because it explains glaucoma, which will for sure pop up. So aqueous humor is produced by the ciliary body, specifically the ciliary processes, and it's first secreted into the posterior chamber, which is the space between the iris and the lens. From there, the fluid flows through the pupil into the anterior chamber, which is the space between the cornea and the iris. This directional flow from posterior chamber through the pupil to the anterior chamber is critical and is driven by continuous production, not by an active pump. So once in the anterior chamber, the aqueous humor moves toward the iridocorneal angle, which is the junction between the iris and the cornea, and this is where drainage occurs. The fluid is reabsorbed through the trabecular meshwork, which acts like a porous filter. And from the trabecular meshwork, the fluid enters the canal of Schlemm, also called the scleral venous sinus. And from there, it's drained into the venous system, eventually reaching the varicose veins. So the key concept is that production is constant and drainage must match it to maintain that normal intraocular pressure. So again, if there's that increased production or more commonly impaired drainage, this is very similar to that hydrocephalus with their ventricles of the brain, right? So impaired drainage, especially at the trabecular meshwork or at the canal of Schlemm, aqueous humor accumulates and intraocular pressure then rises, and this leads to glaucoma. So the high yield flow to memorize is ciliary body to posterior chamber, through the pupil to anterior chamber, into that trabecular meshwork, then the canal of Schlemm, and finally into the venous circulation, and any disruption along this pathway results in increased pressure and potential damage to the optic nerve. Also, this has nothing to do with medicine, but I just got my old 3DS up and running, and I started playing Animal Crossing New Leaf. I named my town the Canal of Schlemm, or it's just Schlemm, but it's the town of Schlemm. So there you go. I'm just a fan of that one. It's a silly name. All right, so now we're going to be getting into our muscles. And first, we're going to have intraocular and extraocular. And we're just going to start with intraocular muscles, okay? So the intraocular muscles of the iris, and these all revolve around autonomics because these are all under involuntary control. So there are 3 smooth muscles inside the eye overall, but 2 of them are in the iris and directly control pupil size. The first is sphincter pupillae muscle, which is under parasympathetic control. And parasympathetic means that rest and digest. So think conserving light. This muscle is arranged in a circular pattern around the pupil, and when it contracts, it constricts the pupil. This is called meiosis. Mechanistically, it works like tightening a drawstring, making the opening smaller. So this pathway is carried by cranial nerve 3, the ocular motor nerve, via parasympathetic fibers that synapse in the ciliary ganglion before reaching the muscle. Clinically, activation of this pathway occurs in bright light to limit the amount of light entering your eye, and in contrast, the dilator pupillae muscle is under sympathetic control, which is your fight or flight system. And this muscle is arranged radially, like spokes on a wheel. And when it contracts, it pulls that pupil open, causing dilation, or what we call mydriasis. Okay? This allows more light to enter the eye, which is useful in low light or high alert situations. So structurally, this muscle anchors near the pectinate ligament and inserts into the posterior epithelium of the iris, allowing it to pull outward when it's activated. That key distinction to lock in is that parasympathetic input causes constriction via that circular sphincter pupillae, while the sympathetic input causes dilation via the radial dilator pupillae. So clinically, this shows up in conditions like Horner syndrome, where there's a loss of sympathetic input that will lead to a constantly constricted pupil, and in the oculomotor nerve lesions, where you have a loss of parasympathetics again, involving that Ettinger-Westphal nucleus that we talked about in Neuro Week 1, and that would also lead to a dilated pupil. And the way I like to remember, if you have trouble remembering what the effects of the sympathetics are on your pupil, I just remember how drugs are represented in most movies. You know, when someone sticks a needle in them, you know, whether it's adrenaline or, you know, something a little bit more fun and illegal, their pupils always become super huge, right? They become massive. And that's because they're super energized, right? Your sympathetic nervous system is activating. So when I think of sympathetics, I just think of drugs, and then I just remember the pupils going, wah, you know, super blown out. And there you go. So you'll probably never forget it there. So just think of drugs when you think of sympathetics in your iris. There you go. Yeah, we're pretty cool here at MooseMed. All right, so now we're going to start covering eye embryology. And there are 3 embryologic tissues that give rise to the eye. You have neural ectoderm, or the neural tube. You have head mesenchyme, and then you have surface ectoderm. And we're just going to focus on neural tube for this slide. So the eye primarily develops from the neural ectoderm, specifically from the diencephalon, which is that part of that forebrain. So right away, you should be thinking of the eyes as an extension of your brain rather than a separate structure. So early on, the neural tube forms what are called optic grooves, which invaginate outward to become the optic vesicles. These optic vesicles grow laterally until they contact that surface ectoderm, and that contact is critical because it induces the surface ectoderm to thicken and form the lens placode. This is a classic example of inductive signaling in embryology. The lens placode then invaginates to form the lens vesicle, which will eventually become the lens of the eye. At the same time, the optic vesicle itself invaginates, essentially folding in on itself and transforms it into a 2-layered structure called the optic cup. So now you have 2 key structures, the lens vesicle from surface ectoderm and the optic cup from neural ectoderm. The optic vesicle also maintains a connection back to the brain through the optic stalk, which will eventually become the optic nerve or cranial nerve 2. Because the optic cup forms by invagination, it creates 2 layers, an inner and an outer layer, and a transient space between them called that intraretinal space. The inner layer will go on to form the neural retina, which contains the photoreceptors and neurons, while the outer layer becomes the retinal pigment epithelium, which supports those photoreceptors. The optic stalk itself undergoes similar folding and contains a groove called the choroid fissure, which allows the hyaloid artery to reach the developing eye. This artery later regresses, but is important during embryology and, development in general. A key high-yield point is that the optic stalk is literally part of the central nervous system, meaning it's covered by all 3 meningeal layers, so that means your dura, your arachnoid, and your pia mater, and carries cerebrospinal fluid around it. And that's why increased intracranial pressure can be transmitted to the optic nerve, leading to findings like papilledema. The big picture to lock in here is that neural ectoderm forms the retina and the optic nerve through the optic vesicles to optic cup pathway, while also inducing the surface ectoderm to form the lens, and the entire system remains structurally and functionally connected to the brain. Here we have a slide that's really just going to drill into those optic cup layers, because we don't want to be missing those easy points on the exam that are just straight up, do you know the process of how this happens, okay? So, once more with feeling. The optic cup forms from that neural ectoderm and differentiates into 2 layers, the outer and the inner layer. The outer layer becomes the retinal pigment epithelium, often abbreviated as RPE, which is a pigmented epithelial layer that plays a critical support role for photoreceptors, which are your rods and cones. It absorbs excess light to prevent scattering and recycles those visual pigments and provides metabolic support to cells that actually detect light. The inner layer becomes the neural retina, which contains the functional circuitry for vision. So within the neural layer, you have three main cell types arranged in this pathway. You have rods, cones, bipolar cells, and ganglion cells. And I know I said three types of cells, and that's because rods and cones are both photoreceptors, okay? So your rods and your cones, bipolar cells, and ganglion cells. Rods and cones detect light and convert that into electrical signals, and bipolar cells act as interneurons, relaying signals from photoreceptors to ganglion cells. Ganglion cells then send their axons toward the optic disc, which is the blind spot, where these axons exit the eye to form the optic nerve, or cranial nerve 2. A key structural concept is that during development, there is initially a space between the inner and outer layers called that intraretinal space, which we touched on the previous slide, but this space normally gets obliterated as they later fuse together. And so this is critical because the photoreceptors in the neural retina depend on the close contact with that retinal pigment epithelium for survival and function. So if that connection is disrupted, the photoreceptors lose their support and begin to degenerate. So clinically, if the infraretinal space fails to obliterate during development, it can cause a congenital retinal detachment. So similarly, in acquired retinal detachment, the same separation occurs later in life, leading to the same fundamental problem, which is that loss of support from the pigment epithelium, which can ultimately cause vision loss or blindness. Okay, so the key takeaway here is that outer layer supports, the inner layer detects and transmits, and the physical connection between them is essential for vision to work at all. All right, so here we're just going to be highlighting the connection between the optic stalk and the optic nerve, or cranial nerve 2. And this is a key concept because it reinforces that the optic nerve is actually part of the central nervous system, not a peripheral nerve. So the optic stalk originates as a connection between the developing optic cup and the forebrain, and as development progresses, it becomes the optic nerve. The outer layer of the optic stalk contributes to the connective tissue covering around the optic nerve, forming the epineurial sheath, while the actual nerve fibers of cranial nerve 2 are derived from the axons of the retinal ganglion cells. These ganglion cell axons grow posteriorly and pass through the optic disc, also known as the blind spot, and fill the lumen of the optic stalk, transforming it into a solid nerve structure. Because these ganglion cells are part of the central nervous system, the optic nerve is myelinated by oligodendrocytes rather than Schwann cells, which is a key distinction from peripheral nerves. This also means that the optic nerve is surrounded by three meningeal layers, the dura, the arachnoid, and pia mater, and it is associated again with that cerebrospinal fluid, which is why, again, that increase in cranial pressure can be transmitted to that optic nerve. Another important developmental structure is that hyaloid artery, which initially supplies the developing lens and retina by traveling through the optic stalk, and over time this artery regresses and its proximal portion becomes the central retinal artery, which is the main blood supply to the inner retina. Finally, the choroid fissure, which forms along the inferior aspect of the optic stalk and optic cup to allow passage of the hyaloid artery, must close during development, typically around week 7. Failure of this fissure to close results in coloboma, a defect that can affect structures like the iris or the retina, depending on the extent of the closure failure. So the key takeaway, again, is that the optic nerve forms from ganglion cell axons filling the optic stalk. It is fully a central nervous system structure with oligodendrocyte myelination and meningeal coverings, and its development is closely tied to that hyaloid artery and proper closure of the choroid fissure. All right, so now we're covering that second tissue that gives rise to the eye, which is that head mesenchyme. Okay, and quickly to touch on the previous slide, don't forget, right, we had three tissues total. It was the head mesenchyme, it was that neural tube or neural ectoderm, and then it was that surface ectoderm. And remember, the neural ectoderm and the surface ectoderm were covered together because them touching each other was important for that vision development, okay? So now we're closing out with head mesenchyme. All right, so by around week 15, this mesenchyme differentiates into two major layers. Dude, these eye embryological structures love doing that. And it's going to correspond to the fibrous and vascular tunics of the eye. So the outer portion of the mesenchyme becomes the dense connective tissue, forming that fibrous tunic, which includes the sclera and parts of the cornea, and this is what gives the eye its structural integrity and toughness. The inner portion of the mesenchyme becomes loose, highly vascularized connective tissue, forming the vascular tunic, which includes the choroid, ciliary body, and the iris. A key detail here is that while the mesenchyme provides the connective tissue and the vascular components of the ciliary body and iris, the epithelium of these structures actually comes from the optic cup, meaning from neural ectoderm, not mesenchyme. That distinction is very commonly tested. Another major concept on this slide is that the formation of the eye chambers happens through programmed cell death, or apoptosis. The anterior and posterior chambers don't just appear, they are carved out as cells in that region are selectively killed. So the iridopupillary membrane initially spans across the developing pupil, blocking the opening between the anterior and posterior chambers, and it's normally broken down around week 28. So once it regresses, the pupil is formed, allowing aqueous humor to form from the posterior chamber to that anterior chamber, and if that membrane fails to regress, it can lead to persistent pupillary membrane, which can obstruct vision. So similarly, the vitreous chamber also forms in part through cell death, but not completely. Some neural crest-derived cells remain and contribute to the stroma of the vitreous body, and this is important because it explains why the vitreous has both a structural gel component and developmental remnants. So the big picture here is that the head mesenchyme builds the structural and vascular net framework of the eye. Apoptosis is what sculpts those chambers, and proper regression of transient embryological structures like the iridopupillary membrane is essential for establishing normal fluid flow and vision. All right, so here we just have a little spotlight on our congenital anomalies that we talked about in previous slides. But the first condition we have is that, again, that persistent iridopupillary membrane, which occurs when that iridopupillary membrane fails to regress. And normally this membrane temporarily covers the developing pupil and breaks down around week 28 through programmed cell death or apoptosis to create that clear opening between anterior and posterior chambers. If it doesn't degenerate properly, strands of tissue remain across the pupil, which can partially obstruct vision depending on the severity. So this is usually a mild finding, but it is important because it directly reflects failure in embryology, causing, eventual developmental problems. And then the second one we have is coloboma, which is a much higher yield structural defect and results from failure of that choroid fissure failing to close during development, typically around week 7. So the choroid fissure is a transient opening along the inferior aspect of the optic cup and optic stalk that allows the hyaloid artery to enter the developing eye. And once it's done, the fissure is supposed to just fuse shut. And if that closure fails, it leaves a gap in the inferior portion of the structures of the eye, most commonly the iris, producing the characteristic keyhole or cat's eye appearance. So depending on how extensive the failure is, coloboma can also involve deeper structures like the retina or optic nerve and can lead to significant visual deficits, but in general, these are pretty benign. They just look kind of funky. The key takeaway here is pattern recognition, right? So if a structure was supposed to disappear and it doesn't, you get persistence, like the iridopupillary membrane. And if the structure was supposed to close and it doesn't, you get a cleft or a gap, like the coloboma. Okay, and now we get into blood supply. I get it? Anyway, I do what I can, all right? Sue me. So this slide is the arterial supply to the eye, and the big picture is actually very clean if you anchor it correctly. So everything comes from the ophthalmic artery, okay, which is the branch of the internal carotid artery. So unlike a lot of other regions, you don't have multiple competing sources. This is essentially a one-source system, which is why loss of flow here is super dangerous and can lead directly to blindness. The ophthalmic artery enters the orbit through the optic canal alongside the optic nerve, cranial nerve 2, and then immediately starts branching. The most clinically important branch is the central retinal artery, which actually pierces into the optic nerve and travels within it to reach the retina. Once it gets there, it branches into medial and lateral or nasal and temporal branches to supply the inner layers of the retina, particularly the ganglion cells and bipolar cells. This is critical because this artery is an end artery, meaning there's no significant collateral circulation, so if it gets occluded, like the central retinal artery occlusion, you get sudden painless vision loss. In contrast, the outer layers of the retina, specifically the photoreceptors, rods and cones, and the retinal pigment epithelium are supplied by the choroid, which receive blood from the ciliary arteries. These ciliary arteries branch off the ophthalmic artery as well and penetrate the sclera to supply the vascular tunic, meaning the choroid, iris, and ciliary body. So the retina has this dual supply system. You have that inner retina from the central retinal artery and outer retina from the choroidal circulation. And that distinction is very testable. So everything else on this slide falls into that category of supporting structures. So the lacrimal artery supplies the lacrimal gland and eyelids, the ethmoidal arteries head towards the ethmoid bone and supply the paranasal sinuses, and the supraorbital and supratrochlear arteries extend superiorly to supply the scalp and parts of the face. The medial palpebral arteries supply the eyelids, and dorsal nasal arteries contribute to blood supply of the nose, often connecting within branches of facial artery, which create anastomoses between the internal and external carotid systems. So the key takeaways here are that the ophthalmic artery is the sole source. The central retinal artery supplies the inner retina and is the end artery. The choroidal circulation supplies the outer retina, and everything else is supporting tissue supplying, branching off of that same vessel. All right, and now since we just covered arteries, we're moving on to veins. And here we're just going to break it down into two main pathways. You have the vorticose veins for most of the eye and the central retinal vein for the retina. So most of the venous blood, including drainage of the vascular tunic and aqueous humor after it exits through that canal of Schlemm, shout out my Animal Crossing town, ultimately leaves through the vorticose veins. So these veins drain into the superior and inferior ophthalmic veins, which then carry blood back toward the cavernous sinus or pterygoid venous plexus. In contrast, the central retinal vein follows that same general pattern as the central retinal artery, but inverse. So traveling within that optic nerve, cranial nerve 2, and draining directly into the cavernous sinus. This is a high-yield distinction because it creates direct connection between the retina and the intracranial venous structures. Another important concept is the presence of anastomoses between the ophthalmic veins and the facial vein, particularly through connections like the angular vein near the medial portion of the eye. The angular vein is right near your nose, okay? So these connections are clinically significant because they allow infections from the face, specifically the so-called danger triangle of the face, to spread into the cavernous sinus. And this is important, right? Because if you have a pathology in that sinus, okay, right? So let's say you have a cavernous sinus infection, it can propagate back and affect the retinal circulation, potentially leading to venous congestion or embolic events in the central retinal vein. So the key takeaway, again, are those vorticose veins handle most of the eye's drainage into the ophthalmic veins. The central retinal veins are a direct pathway to the cavernous sinus, and the venous connections to the face create a route for infection to spread intracranially. Thank you, facial veins. Very nice of you. Thank you. All right. So now we're just connecting increased intracranial pressure to that optic nerve, which we've touched on in previous slides, but now we're just focusing on it. But this is a very high-yield clinical concept because it explains papilledema and why you can literally see the brain through the eye. So increased cranial pressure can result from conditions like meningitis, which is inflammation of the meninges, which again are your dura mater, your arachnoid mater, and your pia mater, or hydrocephalus, which again is when your head is too full of your cerebral spinal fluid from those ventricles, which is mainly due to a blockage, but could be from overproduction, but that rarely happens. But regardless of the cause, the key idea is pressure buildup within the cranial cavity. The reason the optic nerve, or cranial nerve 2, is affected so early on is, again, because it's not a typical peripheral nerve. It actually is an extension of our central nervous system because of that embryology we covered. So that means it's surrounded by, again, those same meningeal layers, like we said, and it sits within the same cerebrospinal fluid as the brain. So because of this, any increase in intracranial pressure will be transmitted directly to that optic nerve. This increased pressure impairs axoplasmic flow within the ganglion cells, axons, that make up the optic nerve, and can also compress the central retinal vessels, disrupting blood flow. As a result, fluid accumulates at the optic disc, which is the point where the optic nerve exits the eye. On a fundoscopic exam, this appears as a swollen, blurred, or puffy optic disc, which is called papilledema. This is a key diagnostic sign because it reflects elevated intracranial pressure rather than a primary eye problem. So early on, vision may be actually relatively preserved, but as that pressure persists, it can lead to progressive visual impairment and eventually permanent vision loss. So the key takeaway is that because the optic nerve is continuous with the brain and shares that surrounding fluid space, any increase in Intracranial pressure will be transmitted directly to the eye, producing papilledema that can be visualized on exam. All right, and now we're finally getting to those extraocular muscles of the eye. All right, so there are 7 muscles total, if you include the levator palpebrae superioris, the LPS, but 6 classic extraocular muscles that are involved with the eye itself. These are all skeletal muscles, meaning they are under voluntary control, and they control the eye position in 3 dimensions: elevation and depression, abduction and adduction, and rotation. The cleanest way to organize this is by innervation first, because that's how exams are usually framing their questions around these guys. So cranial nerve 3, the ocular motor nerve, innervates most of the eye muscles, okay? He does superior rectus, inferior rectus, medial rectus, inferior oblique, and LPS, or levator palpebrae superioris. Cranial nerve 4, the trochlear nerve, innervates only the superior oblique. Cranial nerve 6, the abducens nerve, innervates only the lateral rectus. So an easy way to remember these is just to remember the 2 muscles that the trochlear nerve and the trochlear nerve and abducens control, and then just remember that if it's not either of those, if it has a rectus in the name or oblique, if you're taking a neuro exam specifically around the eye, it's probably 99% chance going to be ocular motor nerve innervated, okay? If it's not those 2 muscles, it's going to be ocular motor nerve, okay? So, functionally, the medial rectus adducts the eye, meaning it pulls it towards the nose. It's medial, it's going to pull the eye medially. The lateral rectus abducts the eye. It's lateral, it's going to pull the eye away. The superior rectus primarily elevates the eye, but also contributes to adduction and intorsion, okay? Adduction or adduction. While the inferior rectus primarily depresses the eye with some adduction and extorsion. So the obliques are a bit more complex and are best understood in context. So the superior oblique depresses the eye when it's adducted and also causes intorsion, while the inferior oblique elevates the eye when it's adducted and causes extorsion. A helpful way to think about it is that the obliques handle vertical movement when the eye is turned inward, while the rectus muscles handle vertical movement when the eye is more straight or abducted. Clinically, these distinctions are crucial. A cranial nerve 3 lesion will result in that down and out presentation that we've covered 100 times because the lateral rectus and superior oblique are now unopposed, along with ptosis due to LPS paralysis, and often a dilated pupil due to that loss of parasympathetic input that cranial nerve 3 also provides through its Edinger-Westphal nucleus. So a cranial nerve 4 lesion leads to difficulty looking down when the eye is adducted, so patients often compensate with a head tilt. So if you see that in a vignette, that's kind of them cluing into you a trochlear nerve. A cranial nerve 6 lesion results in the inability to abduct the eye. So the eye is pulled medially by the unopposed medial rectus. So the key takeaway is organize the nerves, right? So cranial nerve 3 does most of the things. Cranial nerve 4 handles superior oblique. Cranial nerve 6 handles lateral rectus. And then layer in the movement based on whether the eye is abducted or adducted. All right, so this is going to just be giving you that orientation of these muscles within the actual orbit itself. Most of the extraocular muscles originate from the common tendinous ring at the apex of the orbit, which is basically the anchor point at the back of the eye. And from there, they all pull in straight lines, and those are your rectus muscles. So the exception to this rule is the inferior oblique, which is the only muscle that does not originate from the tendinous ring. Instead, it originates from the anterior part of the orbit near the maxilla and wraps around and underneath the eye. So easy way to remember these is that pretty much all these muscles are named after where they are in the eye, so they're not necessarily too difficult to remember, but just some things to keep in mind is that the 2 weird ones are the obliques. So you have the inferior oblique, which does not attach to that tendinous ring, and then you have the superior oblique, which on this diagram here you can see really well, makes kind of a pulley system, and it goes through the trochlea to hook and create a pulley system with your eye there. And that's going to be really easy to identify in practicals and whatnot because of that sling-like positioning. So just take a look at this, make yourself comfortable. Like I said, these are mainly, they're pretty easy to remember just because they're named after where they're at. And the obliques are easy to remember just because of those 2 exceptions. And once again, we just have another slide covering the orientation of those muscle fibers. just from a different point of view for you to be able to appreciate them from a different angle. So again, you have that sling by that superior oblique. And then here you can actually see inferior oblique on the bottom of the eye there wrapping around it. All right, so this slide is about how to test extraocular muscle integrity. And this is where everything kind of comes together with cardinal directions of gaze. And so the key idea is that you're basically isolating each muscle by putting the eye in a position where that muscle becomes the primary mover. So starting simple, the lateral rectus abducts the eye, meaning you ask the patient to look laterally. And that tests cranial nerve 6, the abducens nerve. The medial rectus muscle adducts the eye, so you have the patient look medially towards the nose, which tests cranial nerve 3, the oculomotor nerve. For the vertical movers, you have to first position the eye to isolate them. So the superior and inferior rectus muscles are best tested when the eye is abducted, because in that position, they become the main vertical movers. So for the superior rectus, you abduct the eye and then ask the patient to look up, testing elevation in the abducted position. For the inferior rectus, you abduct the eye and then ask the patient to look down, testing the depression in that abducted position. In contrast, the oblique muscles are best tested when the eye is adducted. So the superior oblique depresses the eye in the adducted position. So when you bring that eye medially and then ask the patient to look down, you are testing cranial nerve 4, or the trochlear nerve, the inferior oblique, which elevates the eye in the adducted position. So if you adduct the eye, then ask your patient to look up, again, you're testing cranial nerve 3. So the pattern to lock in is abduct, then up or down for the rectus muscles, so abduction for the rectus muscles, and then adduction for the obliques, okay? So clinically, this is exactly what you're doing when you have the patient follow that little H pattern, and each segment of the movement isolates a specific muscle and its corresponding cranial nerve. So if a patient can't perform one of these movements, you are immediately able to localize a lesion to a specific muscle and or nerve responsible. All right, so here's a quick overview slide of the temporal region. This is going to be pretty brief because there's really not much going on here that we care much about other than just general anatomy orientation. So the dominant muscle here is that temporalis, which is like the fan-like muscle that's coming down from the temporal region. That's going to be one of your main muscles of mastication, meaning it's involved in chewing. Its main function is going to be elevation and retraction of the mandible, so it helps you close your jaw and pull it backward. Covering this is the temporal fascia, which is a dense connective tissue layer that encloses the muscle and serves as an attachment surface, especially as it spans downward towards the zygomatic arch. Running superficially through this region are the superficial temporal artery and vein, which are terminal branches of the external carotid system. And these are clinically important because the superficial temporal artery is palpable just anterior to the ear and can be involved in conditions like temporalis arteritis, when inflammation can lead to headache and even vision loss if untreated. Innervation of this region includes the auriculotemporal nerve, which is a branch of V3, the mandibular division of trigeminal nerve. And V3 is the only division of trigeminal nerve that carries motor fibers, again, for that jaw jerk reflex. But the auriculotemporal nerve itself is primarily sensory, providing sensation to the temporal region and parts of the external ear. It also carries parasympathetic fibers from the otic ganglion to the parotid gland, which is another high-yield association. So the big picture here is that the temporal region is a convergence zone of muscle, of mastication, superficial vascular structures that are clinically accessible, and sensory innervation from V3, making it relevant for both functional anatomy and clinical conditions involving pain, inflammation, or vascular compromise. All right, so now we're getting into the infratemporal fossa, which is basically a deep anatomical space packed with high-yield structures, especially V3, the mandibular division of the trigeminal nerve, and the maxillary artery. The easiest way to approach this is to first anchor the boundaries so you know where you are in 3D space. Laterally, you have the ramus of the mandible, so think jawbone on the outside. Superiorly, you have the zygomatic arch forming the roof of the space. And medially, or deep, is that lateral pterygoid plate of sphenoid bone, which is key because that's where the pterygoid muscles attach. Anteriorly is the maxilla, and posteriorly, you're bounded by the styloid process region. So overall, the space sits deep to the mandible and below the temporal region. Within this space, the main muscles are the medial and lateral pterygoid muscles, along with the inferior portions of the temporalis. These are all muscles of mastication, meaning they are involved in chewing and are innervated by V3. The lateral pterygoid is especially important because it helps protrude the mandible and initiate opening of the jaw, while the medial pterygoid helps elevate the mandible, working somewhat like a mirror of the masseter. The nerve content here is dominated by V3, which is the only division of trigem that carries both sensory and motor fibers. It exits the skull through the foramen ovale and then branches extensively in this space to supply the muscles of mastication and provide sensory innervation to the lower face, teeth, and anterior two-thirds of the tongue via branches like the inferior alveolar and lingual nerves. Also located here is the otic ganglion, which is a parasympathetic ganglion associated with the glossopharyngeal nerve input that is ultimately sending secretomotor fibers to the parotid gland via the auriculotemporal nerve that we just covered. Vascularly, the maxillary artery is the major arterial supply running through the space, so giving off numerous branches to the deep facial structures, and the pterygoid venous plexus is the main venous network. This plexus is clinically important because it communicates with the cavernous sinus, providing a potential pathway for the spread of infection from face into intracranial structures. So the key takeaway is that the infratemporal fossa is a dense hub containing V3 and its branches, the maxillary artery, which has a ton of branches that we'll get into, the pterygoid muscles, and important venous connections, making it highly relevant for both nerve lesions and infections to spread. All right, so now we are going to be focusing on the temporomandibular joint, or TMJ. So we're staying within that infratemporal space, and we're just going to isolate specific structures and parts of it. And so this is a high yield joint because it's both structurally unique and heavily used. So the TMJ is the articulation between the head of the mandible and the mandibular fossa and articular tubercle of the temporal bone. It's classified as a synovial joint, meaning it has a joint capsule, synovial fluid, and an articular surface, but what makes it weird or unique is that it has an articular disc that divides the joint into two compartments, allowing for both a hinge-like movement and gliding movements, and that's why it's often described as a modified hinge joint. So functionally, this joint allows multiple types of movement. You have depression, elevation of the mandible, which correspond to opening and closing your mouth. You have protrusion and retrusion, which are forward and backward movements of your jaw. You have side-to-side or lateral deviation movements, which are essential for chewing. So these movements are coordinated by muscles of mastication, especially the pterygoids. The lateral pterygoid is particularly important because it's the primary muscle responsible for protrusion and of the mandible, and also helps initiate opening of the jaw, pulling the mandibular condyle and articular disc forward onto the articular tubercle. Clinically, the joint is prone to dislocation, especially with excessive depression of the mandible, like when someone opens up their mouth too wide during yawning or dental procedures. In this situation, the mandibular head can slip anteriorly past the articular tubercle and get stuck, making it difficult for the mouth to close. Because of the proximity of important nerves, particularly branches of V3, dislocation or inflammation of the TMJ can lead to pain that radiates to the ear or temporal region. And so the key takeaway is that the TMJ is a specialized synovial joint with that articular disc that allows for both hinge and gliding movements, and it is controlled by the muscles of mastication, especially the lateral pterygoid for protrusion, and is clinically important due to its susceptibility to dislocation and associated nerve-related pain. Now we are hyperfixating on our muscles of mastication, which all are derived from pharyngeal arch 1, which means they're all innervated by trigeminal nerve, but specifically V3, okay, which is that third branch of trigem, and that's called the mandibular division. So functionally, it's classified as SVE, which stands for special visceral efferent, which is motor to muscles derived from pharyngeal arches. So starting with temporalis, it originates from the temporal lines and infratemporal crest and inserts on the coronoid process and anterior surface of the ramus of the mandible. Functionally, it elevates and retracts the mandible, so it closes the jaw and pulls it backwards. This is your clenching muscle, especially the posterior fibers for retrusion. Next is the masseter, which originates from the zygomatic arch and inserts on the lateral surface of the mandible. And its primary function is elevation of the mandible, making it one of the strongest closers of the jaw. It's innervated by branches of V3, specifically the masseteric nerve, and is heavily involved in forceful biting. The medial pterygoid is positioned internally and mirrors the masseter in function. It originates from the lateral pterygoid plate and maxilla and inserts onto the medial surface of the ramus of the mandible. Initially, it elevates the mandible and assists with protrusion, and when acting unilaterally, it contributes to that side-to-side movement of the jaw, which are essential for grinding food. The lateral pterygoid is the outlier in terms of function. It originates from the lateral pterygoid plate and infratemporal crest and inserts onto the neck of the mandibular condyle and the articular disc of the TMJ. Instead of closing the jaw, the lateral pterygoid is primarily protruding the mandible and assists in depression, meaning it helps open the jaw. It also contributes to side-to-side movement when acting unilaterally. So the key pattern to lock in is that temporalis, masseter, and medial pterygoid all elevate and close the jaw, while lateral pterygoid opens and protrudes the jaw. All are innervated by V3 because they come from arch 1, and their coordinated action allows for complex movements like chewing, which involves elevation, protrusion, and lateral deviation working together. All right, so this slide is just going to be setting up our big boy, the maxillary artery, okay? And we're going to break this down later. So the goal here is just to anchor the big picture without getting lost in all the branches. So the maxillary artery is one of the two terminal branches of the external carotid artery, and it's the dominant arterial supply of the infratemporal fossa and many deep facial structures. It runs deep to the mandible, which is why it's clinically vulnerable, and so like fractures of the neck of the mandible can damage the maxillary artery and lead to significant bleeding. So the reason this artery feels overwhelming is because it has about 16 branches. So instead of memorizing them as a list, everything is just going to be organized into 3 parts on its anatomical relationship to the lateral pterygoid muscle. You will have to memorize all 16. I am so sorry, but I break down each part in its own slide. So we're going to do it in bite-sized portions. So part 1 is the mandibular portion, which lies posterior to the lateral pterygoid and primarily supplies structures associated with the mandible, including things like the inferior alveolar artery. Part 2 is the pterygoid portion, which runs either superficial or deep to the lateral pterygoid and mainly supplies the muscles of mastication. Part 3 is the pterygopalatine portion, which is more anterior and passes into the pterygopalatine fossa, where it gives off branches that supply deeper structures like the nasal cavity, palate, and orbit. So for now, the key takeaway is not the individual branches, but the organization of it, right? So you have maxillary artery off the external carotid, and that's going to travel into the infratemporal region, and it's divided into 3 parts based on lateral pterygoid, and is clinically important because of its importance to the mandible and extensive branching. So once you understand this framework, it's a lot easier to dive in and break everything up. All right, so here we go. Part 1 of the maxillary artery, the mandibular portion. And this is the easiest section to memorize if you organize it by target instead of just listing branches. So this part sits posterior to the lateral pterygoid muscle and gives off 5 branches, which cleanly break into a pattern. 2 to the ear, 2 to the meninges, and 1 to the mandible. So starting with the ear, you have the deep auricular artery, which supplies the external acoustic meatus, basically the deep part of your external ear, and you have the anterior tympanic artery, which goes to your middle ear. So that's your 2 to the ear bucket. Next, you have the meningeal arteries, and this consists of the middle meningeal artery, which is the big one here, and it enters the cranial cavity through the foramen spinosum and supplies the dura mater. This is a high-yield vessel because it runs deep to the pterion, a thin area of the skull, and can be torn in trauma, leading to an epidural hematoma. The accessory meningeal artery is smaller and just provides additional support to the meningeal blood supply, so that gives you your 2 to the meninges. Finally, the inferior alveolar artery is the one going to the mandible. It enters the mandibular foramen and travels within the mandibular canal to supply the lower teeth, which is why it's clinically relevant for dental anesthesia and procedures. So that's on your 1 to the mandible section. So again, part 1 equals those 5 branches of organized as 2 to the ear, 2 to the meningeal, 1 to the mandibular. And if you remember that distinction, you can kind of have your guesswork on the exam be pretty solid. All right, so now we're moving on to part 2 of the maxillary artery, which is that pterygoid portion. And the key idea here is that this section is almost entirely muscular supply, which is why the branches are more variable and less cleanly patterned than part 1. So anatomically, this portion runs in relation to the lateral pterygoid muscle, either superficial or deep to it, and its job is pretty straightforward. Supply the muscles of mastication plus 1 extra structure. So there are 5 branches, and the easiest way to organize them is 1 for each muscle of mastication plus 1 for the cheek. So starting with the muscles, the masseteric artery goes to the masseter muscle. The pterygoid branches supply both medial and lateral pterygoids. And then you have the anterior and posterior deep temporal branches, which ascend to supply the temporalis muscle. And that covers pretty much all four major muscles of mastication. You have masseter, temporalis, medial pterygoid, and lateral pterygoid. And so the final branch is the buccal artery, or buccal, or I don't know. I've heard this one pronounced so many different ways. Buccal. I don't. If you do that one, that's you gotta go see someone for that. I'm a fan of buccal. So the final branch is the buccal artery, which supplies the cheek, specifically the buccinator region. So that's your +1. Okay. So instead of memorizing the random names, right, just think functionality. You have to have one for each of your mastication muscles, and they're named pretty appropriately. And then you have the one go into your cheek, which is also part of your chewing process. Buccinator helps out in one way or another with mouth movements. So if you just think mastication and eating for part 2, that'd be pretty good. All right, so part 3 of the maxillary artery is the pterygopalatine portion. The reason I say teaser here is because we're going to revisit this much later in the video when we actually cover the structures that are relevant to the supply here. So we're gonna just briefly overview it here, but just for completion's sake, since we're covering the maxillary artery, I just wanted to lay the framework here. So so the pterygopalatine portion, this is where things shift from local muscles of the mandible to deep face, orbit, nasal cavity, and palate stuff, which we'll get to at the end of this video. So think of this section as the distribution hub to deeper structures. And anatomically, this portion sits anterior to the lateral pterygoid and enters the pterygopalatine fossa, which is basically a central crossroads that communicates with the orbit, nasal cavity, oral cavity, and pharynx. And that's why the branches here look so scattered. They're going to different directions to reach different things. So there are 6 branches, and instead of memorizing them as a flat list, again, it's much easier to group these by where they're going. So the posterior superior alveolar artery goes to the maxillary teeth, especially the upper molars. So when you see alveolar in the name, that means teeth. And superior inferior just means, are we on the top teeth or the low teeth? Then we have the infraorbital artery, which travels through that inferior orbital fissure into the orbit and then comes out onto the face, supplying structures under the eye. The descending palatine artery goes inferiorly to supply the palate. The structure of the pterygoid canal runs posteriorly towards the upper pharynx and auditory tube region. The pharyngeal artery also contributes to the nasopharynx. And finally, the sphenopalatine artery is the big high-yield one because it enters the nasal cavity and is the major supplier of the nasal septum, making it a key player in posterior epistaxis. So the takeaway here is that part 3 equals deep distribution, okay? Teeth, orbit, palate, pharynx, and nasal cavity. If you anchor each branch on that destination, just think of the name, right? So again, when reviewing these, just break them up, take them step by step. All right, so this slide is just going to be tying together venous drainage of the infratemporal fossa, and the key idea here is that everything here is a network. So it's not just a single straight vein. You want to be thinking plexus, consolidation, systemic drainage. So it starts with the pterygoid plexus of veins, which is a dense venous network located around the pterygoid muscles, and this plexus collects blood from the deep fascial structures, especially the teeth, nasal cavity, and muscles of mastication. So it's basically the venous equivalent of the maxillary arteries distribution. From there, the plexus condenses into the maxillary vein, which then joins with the superficial temporal vein to form the retromandibular vein. So the major outflow pathway eventually draining into larger venous systems like the external jugular vein go plexus, maxillary vein, retromandibular vein. So the high-yield clinical piece is the emissary veins. So these are valveless connections between the pterygoid plexus and the cavernous sinus inside the cranial cavity. Because they lack valves, blood, and more importantly, infection can travel retrograde. And this means that infections from face, teeth, or infratemporal regions can spread directly into that cavernous sinus and leading to cavernous sinus thrombosis, which is a serious and potentially life-threatening condition because of how many important structures run through that cavernous sinus. So the takeaway is pterygoid plexus is the hub, the retromandibular vein is the main exit, and the emissary veins are the dangerous shortcut to the brain. All right, and boom, jump scare, trigem. All right, and this is just don't forget it, right? I know we covered this in the last video, but just because we're in this infratemporal region, guess who lives here? Mr. Trigem, right? So cranial nerve 5, the trigeminal nerve, specifically V3, the mandibular region, which is one of the ones that matters the most for the infratemporal fossa. It's the key spatial relationship is that V3 runs deep to the lateral pterygoid muscle, so anytime you're in this region anatomically, you should assume V3 and its branches are nearby. So functionally, V3 is unique because it's the only mixed branch of trigem, meaning it carries sensory and motor fibers, unlike V1 and V2, which are purely sensory. So from a motor standpoint, V3 innervates all the first pharyngeal arch muscles, which is high yield, right? That includes the four muscles of mastication, which are masseter, temporalis, medial pterygoid, and lateral pterygoid, as well as the mat muscles. Remember our mnemonic from video 1, mast and mat? So this is the mat part here. So mylohyoid, anterior belly of digastric, tensor tympani, and tensor vili palatini, the one that sounds like Italian brain rot. I hate that one so much. So the mylohyoid and anterior belly of the digastric are supplied via the nerve to mylohyoid, which branches off the inferior alveolar nerve, so they are often labeled as mixed in terms of their nerve pathway context, even though their fibers are still coming from V3. Even though their motor fibers are still coming from V3, that is. So sensory-wise, the trigeminal nerve defines the three major facial dermatomes, V1 for the forehead and the eye region, V2 for the midface, V3 for the lower face and jaw. But for this block, the emphasis is on V3 because it ties directly into everything we've been building on, right? Those muscles of mastication, infratemporal fossa, contents of the mandibular structures. So the takeaway is V3 equals mixed nerve. It lives deep to that lateral pterygoid muscle, motor to all arch 1 muscles via the muscles of mastication, plus that mat, and sensory to the lower face. So if you lock that in, it pretty much connects almost everything that we've covered in this region. All right, so this is the slide where V3 actually becomes clinically usable instead of just a concept. So think of it as organized into 3 buckets again. We have our motor branches or sensory branches and the one important mixed nerve. So starting with the motor, these are SVE, special visceral efferent, which again just means they came from those pharyngeal arches. So V3 gives 8 motor branches. This is going to be one branch to each muscle we listed earlier. So the 4 muscles of mastication, masseter temporalis via the deep temporal nerves, medial pterygoid and lateral pterygoid, plus the mat muscles, which again are mylohyoid, anterior belly of digastric, tensor tympani, and tensor vili palatini. So again, if you just know that V3 is all arch 1 muscles, you can reconstruct this list no problem under pressure, right? So now the sensory side is much cleaner. We have 3 main branches. We have the buccal nerve, which is purely sensory to supply the cheek, named after Buccinator, which is a classic test point because people confuse it with the Buccinator muscle, which is actually controlled by the facial nerve, not V3. Okay, so V3 is going to be that sensation. Facial nerve, since it does your facial expression, is going to be controlling your cheeks, right? You're going to need your cheeks for facial expression, which is why facial nerve does the motor aspect of that. Again, remember, that's also easy to remember because the only motor aspect that V3 provides is for chewing. It's for that jaw jerk reflex, okay? So anyway, moving on, we have the lingual nerve, and that's going to carry general sensation from the floor of the mouth and the anterior 2/3 of the tongue, and it also picks up special taste fibers from the chorda tympani, which is a branch of the facial nerve. So this is a key example of a nerve hitchhiking, and we're going to see this a lot moving forward. So the auriculotemporal nerve wraps around the middle meningeal artery here, and this is another favorite testable relationship because it's just iconic and it's easy to observe in real life, and it provides sensation to the temporal region of the external ear, and it also carries parasympathetic fibers to the parotid gland from cranial nerve 9. Finally, the inferior alveolar nerve is your mixed nerve. All right, this is the one with the jaw jerk reflex, and it enters the mandibular foramen. And it runs through the mandibular canal and provides sensory innervation to the mandibular teeth and eventually exiting as the mental nerve to supply the chin. Before it enters the canal, it gives off nerve to mylohyoid, which carries motor fibers to the mylohyoid and anterior belly of digastric. So this is one of those nerve bridges, both sensory and motor functions, which is why it's separated out here. So again, that's the inferior alveolar nerve. So the high yield structures here are that V3 splits into motor branches to all arch 1 muscles, 3 major sensory branches, which are going to be your buccal, your lingual, and your auriculotemporal, and 1 mixed nerve, which is the inferior alveolar nerve. And if you just keep that framework, again, you can rebuild it pretty quickly. All right, so here we are having our first classic hitchhiker concept, and this is going to be very, very, very testable. Okay, so the chorda tympani is a branch of the facial nerve, cranial nerve 7, and it carries two things. Special sensory for taste from the anterior two-thirds of the tongue, which is SVA, special visceral afferent, and parasympathetic fibers, which are GVE, general visceral efferent, to salivary glands. It exits cranial nerve 7 and it passes through the middle ear cavity and then joins the lingual nerve, which is a branch of V3. So from that point on, the lingual nerve is basically carrying its own general sensory fibers plus these hitchhiking fibers from cranial nerve 7. So for the taste pathway, the cell bodies live in the geniculate ganglion, and the central processes go to the nucleus solitarius in the brainstem, and that's your sensory side. But clinically, the more important piece is the parasympathetic pathway. Those preganglionic parasympathetic fibers originate in the superior salivatory nucleus in the brainstem, and they travel with cranial nerve 7, then via chorda tympani, hitch a ride on the lingual nerve, and then synapse in the submandibular ganglion. And from there, postganglionic fibers go to the submandibular and sublingual glands to simulate salivation. So the high-yield takeaway is that cranial nerve 7 provides the function, but cranial nerve V3, specifically the lingual nerve, provides the transportation. If the lingual nerve is cut proximal to where chorda tympani joins, you can lose, you just lose general sensation only. But if it's cut distal to that junction, you lose general sensation and taste, and parasympathetic input to the salivary glands. So that distinction is going to be pretty important when talking about lesions. The way I also like to remember some of the nuclei here, I know this is a little bit out of the scope of this slide, but just, I like to give you guys easy ways to remember the nuclei and how they're responsible for what. Nucleus solitarius, I always like to say it with a really fun Italian accent, like nucleus solitarius or something like that. I don't know, that's not even Italian, but whatever. So sorry to any Italians. But I just say it like that because, it's a fancy chef, nucleus solitarius. So he cares about taste, he's defined, he's exquisite, right? And because he's so picky and cares about taste, and I get into this a little bit later, not only is nucleus solitarius responsible for taste, it's also important for your blood pressure monitoring as well as your oxygen perfusion. And that's super random when it comes to taste, right? You would think. But the way I like to make sense of it in my brain, and I don't necessarily know if this is correct, but it has helped me so far, so bear with me. When you are up in an airplane and you're flying, you have shittier taste. You do due to some science stuff I don't necessarily understand just yet, but which is why most of the food they give you on an airplane is salty, is because you can taste salt really well. And that's how I remember that connection of nucleus solitarius to taste, as well as differences in pressure and oxygen perfusion. Okay, just that weird airplane analogy there because of what happens to your taste buds on an airplane. I mean, I'm sure nucleus solitarius has something to do with it, but because of the scope of this video, I'm not going to break it down because this isn't a PhD paper. But that's just an easy way to remember how nucleus solitarius is responsible for taste, as well as your carotid body and sinus, which the carotid body does blood pressure and the sinus does oxygen perfusion. All right, so this is the other major hitchhiker pathway, but now instead of cranial nerve 7, you're dealing with cranial nerve 9, okay? So the glossopharyngeal nerve, and the target here is the parotid gland. The core concept is the same. One nerve provides the function, and the other one provides the physical route. So here, cranial nerve 9 provides the parasympathetic input, and V3, specifically the auriculotemporal nerve, acts as the delivery system. So start at the origin. You have your preganglionic parasympathetic fibers, arise from the inferior salivatory nucleus in the brainstem. And these fibers travel with cranial nerve 9 and then branch off at the tympanic nerve, which enters the middle ear and contributes to the tympanic plexus. From there, the fibers reorganize into the lesser petrosal nerve, which exit the skull and synapse in the otic ganglion, located just medial to V3 in the infratemporal fossa. After the synapse, the postganglionic parasympathetic fibers need a way to reach the parotid gland, and this is where V3 comes in. They hitchhike along the auriculotemporal nerve, a sensory branch of V3, which carries them to the parotid gland to stimulate that salivation. So the high-yield pathway is inferior salivatory nucleus, cranial nerve 9, tympanic nerve, tympanic plexus. Then once it exits it renames itself the lesser petrosal nerve. Then you have the otic ganglion, and from there it's going to synapse. And then you have the auriculotemporal nerve, V3, and it's going to use that V3 to get to the parotid gland to make you salivate. So the pattern should look familiar, with cranial nerve 9 providing that parasympathetic signal and V3 providing that transportation. So this mirrors that chorda tympani with the lingual nerve setup, just with a different cranial nerve and a different salivary gland, right? So the other one is with the submandibular and sublingual, and this one is the parotid. And again, with the nuclei, the way I like to remember that inferior salivatory nucleus is for the parotid and superior is for submandibular and sublingual is because the parotid physically is higher than the other two. So the nucleus is just named opposite for its location. It's the inferior salivatory nucleus for the superior gland, and it's the superior salivatory nucleus for the inferior glands, which are the submandibular and sublingual. I just remember that it's flipped. All right, and this slide is just going to give you who actually enters the orbit checklist, and it's just very high yield anatomy to know because, the clinical deficits will happen, together in most cases. So the key idea here is that almost everything in the orbit is either vision, eye movement, or sensation, and each cranial nerve here maps cleanly onto one of those roles. So I like to start with cranial nerve 2, which is the optic nerve, and it's purely sensory, right? And that's vision, SSA, and it carries information from the retina to the back of the brain and passes through that optic canal, not the superior orbital fissure, which is an easy distinction to test. So remember, optic canal for that optic nerve. Next is cranial nerve 3, the ocular motor nerve, which is doing most of the heavy lifting, and it has GSE fibers, general somatic efferent, to most of the extraocular muscles, plus GVE parasympathetic fibers to the sphincter pupillae for pupil constriction and the ciliary muscle for accommodation. So cranial nerve 3 is both movement and autonomics. You have cranial nerve 4, the trochlear nerve, is GSE, and it innervates just one muscle, that's superior oblique, which is our sling muscle. Remember, it goes to that little pulley system. And then we have cranial nerve 6, the abducens nerve, also GSE, innervates that lateral rectus, which is going to abduct the eye, and it's especially vulnerable to increased intracranial pressure because of its long intracranial course. So a down and in eye often points to cranial nerve 6 issues. Cranial nerve V1, okay, so the ophthalmic division of trigeminal nerve, is purely sensory, GSA, general somatic afferent, and supplies the cornea, upper eyelid, forehead, and nose. So this is your afferent limb of the corneal reflex, which we'll get into later, has its own slide. So cranial nerve 7, okay, does not pass through the orbit, but it's still functionally tied to it. It innervates orbicularis oculi to close the eyelids and carries parasympathetic fibers to the lacrimal gland via those hitchhiking pathways that we covered. So clinically, it absolutely affects the eye, even though it doesn't enter the orbit itself, which is why it's here. So the clean framework is cranial nerve 2 for that vision, 3, 4, 6 for the eye movement, and then don't forget 3 also does those parasympathetics, V1 for the sensation of the eye, someone poking you in the eye, and 7 is the associated but not present guy. If you just remember that, you'll be all right. All right, so eye movement, vision, and then 7 because he loves giving people a ride. All right, so we've talked about the cavernous sinus so much in the previous slides, and now I'm just giving it its own slide because, it's really important clinically because of all the structures that run through it. So it's important for infectious reasons, etc. So it's just important for clinical presentation. So the key distinction is that the internal carotid artery and the abducens nerve run directly through the sinus itself, essentially exposed within the venous blood. Okay, so in contrast, the ocular motor nerve or trochlear nerve and the ophthalmic and maxillary divisions of the trigeminal nerve, so that's V1 and V2, are tucked into the lateral wall of the sinus, which gives them a bit more protection early on in a disease process. So this arrangement matters most when you think about pathology. Because cranial nerve 6 is literally floating within the sinus next to the internal carotid artery, its most vulnerable structure, and it's the most vulnerable structure and is typically the first nerve affected when something goes wrong, such as a cavernous sinus thrombosis or an expanding aneurysm. So clinically, that shows up as a lateral rectus palsy, meaning the patient cannot abduct the eye. The unopposed medial rectus muscle pulls the eye inward, so you get medial deviated eyes and a horizontal diplopia. So if the condition if the condition progresses, the pathology starts to involve the nerves in that lateral wall, leading to deficits in cranial nerve 3 and 4. which further disrupt those eye movements, and eventually V1 and V2, which cause loss of facial sensation in their respective distributions. So you also need to connect this to the venous drainage and infection spread that we covered earlier. So the cavernous sinus communicates with that facial nerve, and particularly through the angular and ophthalmic veins, which means infections from that danger triangle, right, that angular vein of the face, can track back into the sinus. And when that happens, you can get cavernous sinus thrombosis. And instead of a single nerve deficit, you see multiple cranial nerve palsies affecting eye movements and facial sensation stimulation. So on top of that, involvement of the internal carotid artery can create vascular complications, including compression effects or even an aneurysm formation. So the high yield takeaway is not just memorizing what's there, just understanding the pattern that 6 is the thing that's hit first because it's unprotected, and everything else will follow the lesion as it expands outward. So if you keep that mental image of V6 I say V6 just because of the Roman numeral, sorry folks, I mean at cranial nerve 6, abducens. When you see, when you just imagine abducens floating in the sinus and 3, 4, V1 and V2 are in the wall, you can work your way through almost any clinical question regarding the cavernous sinus. All right, and then speaking of those lesions, this is a slide dedicated to those lesions. Okay, so at a baseline level, you need to anchor yourself to a rule. So cranial nerves 3, 4, 6 are the motor supply to your eye, right? 3, 4, 6 make your eyes do tricks. We've said it last video. I'm going to say it again. So cranial nerve 3, again, does most of the work, right? It does everything except for superior oblique and lateral rectus, okay? Which is going to be supplied by cranial nerve 4 and 6, respectively. So where this becomes high yield is when you start thinking through lesions. So a cranial nerve 3 lesion is the most dramatic because you lose multiple muscles at once, right? That's your main guy. Not only that, your eyelid starts to droop a little because of that loss of LPS, and the eye gets pulled into a down and out position because the only muscles still functioning are the lateral rectus and superior oblique. On top of that, cranial nerve 3 carries parasympathetic fibers, so you often also see a dilated pupil. It's not subtle. This is pretty noticeable. So the eye is going to look pretty obviously wrong. A cranial nerve 6 lesion or a cranial nerve 4 lesion is much more subtle and therefore easier to miss unless you know what to look for. So the superior oblique primarily depresses the eye when it's adducted. So patients often complain of vertical diplopia, especially when going downstairs or reading. They compensate by tilting their head away from the affected side to realign the visual fields. So if you see a head tilt in a question stem, they are almost always going to be pointing you toward that trochlear nerve. Cranial nerve 6 lesion is pretty straightforward, but it's common. So especially common in that increased intracranial pressure due to the reasons we listed in that previous slide. So since the lateral rectus is lost, the eye cannot abduct and instead drifts medially due to that unopposed medial rectus. So patients present with horizontal diplopia, and this nerve is particularly vulnerable because of its long intracranial course, which ties directly back to what we just learned about that cavernous sinus. So so if you just want to, you just want to be thinking about what each of these nerves are responsible for, okay? And remember that when we are just looking straight ahead, your eye isn't at rest. To keep you looking straight, all these muscles have to be opposing each other to make you look straight forward. So it makes sense that if one of them stops working, your eye's going to start to drift like a little chameleon. We're not chameleons. We're not built like that, right? So you want them all engaged and active in moving your eyes where you want them to be. All right, so this slide is going to be doing two important things. So we're separating vision from sensation and then sneaking in autonomics through V1 as a delivery system. So if you don't separate those cleanly, these topics get pretty confusing. So start with the optic nerve. Cranial nerve 2 is purely special sensory afferent, meaning it is only responsible for vision. It carries signals from the retina back to the brain, and that's it. No pain, no touch, no autonomics, purely vision. The reminder here about oligodendrocytes is important to reinforce because remember, cranial nerve 2 is part of our central nervous system, not a typical peripheral nerve, which is why it's myelinated by those oligodendrocytes. Everything else on this slide shifts to the trigeminal nerve, specifically the ophthalmic division, V1, and this is your general sensory supply to the eye and surrounding structures. So when the patient feels pain in the cornea or irritation of the conjunctiva or sensation from the upper eyelid or forehead, that's V1 doing all the work. It also covers regions nearby, like the nasal cavity and the ethmoid sinuses, which is why sinus issues can be present with orbital pain. The part that tends to trip some people up is that V1 is not generating autonomics, but it's carrying them. So parasympathetic fibers that originate from cranial nerve 3 synapse in the ciliary ganglion and hitchhike along branches of V1, specifically the short ciliary nerves, to reach the sphincter pupillae and ciliary muscles. And that's how you get the pupillary constriction and accommodation. On the sympathetic side, fibers coming from the superior cervical ganglion also travel along V1 pathways to reach targets like the dilator pupillae and superior tarsal muscle. So V1 is essentially acting as a distribution highway for both parasympathetic and sympathetic signals. So clean way to organize it is cranial nerve 2, vision only, V1 is sensation plus carrier for autonomics, and if you keep that distinction straight, you're fine. All right, so here we're going to be covering the 3 divisions of V1, and this is the NFL division, okay? Easy to remember because NFL, National Football League, NFL is the name of the 3 branches. So the first one is the nasociliary nerve, and it is the most clinically important of the 3, even though it doesn't sound like it at first. It runs deeper into the orbit, and it is heavily tied to the eye itself and nasal cavity. This is the branch that gives off the long ciliary nerves and connects with the ciliary ganglion, which means it's directly involved in corneal sensation and in carrying autonomic fibers to the intraocular structures. So if you think about the corneal reflexes or eye pain, you should be thinking nasociliary. It also sends branches to nasal cavities via the anterior and posterior ethmoidal nerves, which explains why orbital and nasal symptoms can overlap. The frontal nerve is much more superficial and straightforward. And it's essentially just splits into the supraorbital and supratrochlear nerves, which then exit the orbit and supply the forehead and scalp. This is your forehead sensation branch. If someone has numbness over the forehead or after a trauma or lesion, this is the division you should be thinking about. It's not doing anything fancy with autonomics or the globe itself. It's just simply carrying sensation to that skin. The lacrimal nerve is also fairly superficial, but has a unique role because of its connection to tear production. On its own, it provides general sensory innervation to the lacrimal gland and upper eyelid. However, the key detail is that it picks up parasympathetic fibers that originate from facial nerve via V2 and the zygomatic branch, and then delivers them to the lacrimal gland. So even though it's a V1 branch, it ends up being part of the pathway for tear secretion. So again, this is a recall to one of those hitchhiking pathways, right? So if you organize it cleanly, nasociliary is deep and tied to eyes and autonomics, frontal is superficial and goes to the forehead, and the lacrimal is superficial but functionally important for tear distribution. All right, so here we're just going to be isolating the parasympathetic control of the eye, and the key is to follow the pathway step by step without mixing it with somatic motor stuff you just learned. So everything here is going to start with the Edinger-Westphal nucleus, which is the parasympathetic nucleus associated with cranial nerve 3 in the midbrain. So from there, preganglionic fibers travel with the ocular motor nerve into the orbit. And this is important because these fibers are riding along cranial nerve 3, but they are not responsible for eye movement, right? Which is like the big thing behind ocular motor nerve. They are purely autonomic, okay? So once these fibers reach the ciliary ganglion, they're going to synapse, and that's your one and only synapse in this pathway. So then after that, the postganglionic fibers leave the ganglion and hitchhike along branches of V1, specifically the short ciliary nerves, to reach their targets. This is another classic example of that hitchhiking, where cranial nerve V1 is just acting like a delivery route, but not the original source of the signal. So the final targets are the sphincter pupillae, which constrict the pupil, and the ciliary muscle, which controls lens accommodation for near vision. So clinically, this pathway is most often tested through what happens when it fails. If the parasympathetic fibers carried by cranial nerve 3 are disrupted, you lose the ability to constrict the pupil. The sympathetic system is still intact, so it dominates it, and the pupil becomes super dilated. That's why when you see unilateral mydriasis that's why you see that unilateral mydriasis in a cranial nerve 3 lesion. So this is also why people emphasize that parasympathetic fibers run superficially on cranial nerve 3. They are especially vulnerable to compression, such as from an aneurysm, and pupil dilation is that early sign. All right, so here we have our sympathetic counterpart to what we just learned, and the easiest way to understand it is to think of it as a system that does the opposite of cranial nerve 3 parasympathetics. So instead of constricting the pupil, all we're going to be doing is going to be dilating the pupil, and this is to keep the eyelid. And in addition to this, we're also going to keep the eyelid slightly elevated. Okay, so everything with sympathetics is going to be letting light into your eye. Okay, so keeping that eyelid more open and dilating that pupil. So the pathway starts much lower than the parasympathetic one, and it takes a bit of a roundabout way. So originating in the lateral horn of the spinal cord, okay, at levels T1 and T2. Okay, so from there, preganglionic fibers are going to ascend through the sympathetic chain until they reach the superior cervical ganglion, where they're going to synapse. After that, the postganglionic fibers travel along the internal carotid artery, forming a plexus, and then enter the skull in orbit. And just like before, these fibers don't always travel alone. They're going to hitchhike along existing nerve pathways, including branches associated with V1 to reach their final targets in the eye. So the main targets here are going to be that dilator pupillae, which is going to widen the pupil, and superior tarsal muscle, which contributes to keeping that upper eyelid elevated. And this is why sympathetic tone gives you a more alert eye appearance, a larger pupil, and a slightly more open eyelid. So clinically, when this pathway is disrupted, you're going to get the opposite effect. The pupil is not going to be able to dilate, so it's going to be constricted, producing miosis. At that same time, a loss of sympathetic input to the superior tarsal muscle leads to a mild drooping of the eye. It's not completely closed, because remember, we still have that voluntary control over the LPS, or levator palpebrae superioris, okay? But it will be a slight droop, okay? So this is a combination, this combination is part of Horner syndrome, which again is going to be that loss of sympathetic effects. And that's going to, include decreased sweating on the side of the face that's affected, but that all depends on where the lesion is located. So if you compare both systems side by side, parasympathetics via C3 or cranial nerve 3 constrict the pupil and focus vision, while sympathetics from T1 and T2 dilate the pupil and support eyelid elevation. And if the parasympathetic pathway is lost, the pupil becomes dilated. And if the sympathetic pathway is lost, the pupil becomes constricted. All right, and this slide is just going to be tying together everything we just learned into functional circuits. And the key is to think of everything as like a reflex loop with sensory input and motor output, right? So this is reflexes, right? So there's no higher cortex functioning occurring. This is just immediate. Your body just knows to do this without even thinking. So the pupillary light reflex is the most classic one. The light is going to enter the eye and is detected by the retina. So the afferent limb is cranial nerve 2, and that signal is going to travel back to the brainstem and then project bilaterally to the Edinger-Westphal nucleus, or nuclei. There's two of them, right? It's bilateral. And because of that bilateral connection, shining light into one eye causes both pupils to constrict. So the efferent limb is going to be cranial nerve 3, which carries parasympathetic fibers to sphincter pupillae. And that's why you always get both a direct and consensual response. So, and by direct meaning, when you shine light into one eye, that one eye will constrict, but even the light that's not getting light shown in it will constrict as well, okay? That's the consensual response. So clinically, this reflex is extremely useful because you can localize lesions by comparing whether the input side or the output side is broken. So the corneal reflex works differently but follows the same logic. So touching the cornea sends a sensory signal through cranial nerve V1, specifically the nasociliary branch, and that's going to be your afferent limb. The brainstem then activates the facial nerve, cranial nerve 7, which causes the contraction of orbicularis oculi and then blinking. So that's going to be the efferent limb. If someone doesn't blink when you touch their eye, you can test each side to determine whether the problem is sensory input through V1 or motor output through V2. The accommodation convergence process is more complex but still follows a similar structure. So the afferent limb again is cranial nerve 2, so you are detecting an object is coming close to your face. And the efferent limb is cranial nerve 3, but now it's doing 3 things at once. So the first thing it's doing, it's activating the ciliary muscle to round the lens for nearer vision. It's going to be constricting the pupil via sphincter pupillae, and it's going to be activating the medial rectus muscle to adduct both eyes so they converge on the object. That's the combination. So lens thickening, pupil constricting, and eyes converge. That's basically what it's doing. And the way I like to remember that lens stuff, because I know the lens can sometimes seem a bit backwards with since when the muscle contracts, your lens is going to be more relaxed, whereas when the muscle is relaxed, the lens is going to be more flat. But the way I like to think about it is if a ball is coming right at your face, right? So it's right up close to your face, your lens will assume the shape of the ball. It will become ball-shaped. If the ball is in your face, the lens will become the ball to help you see the ball close up. And that's the way I kind of remember that. And then I just remember that the muscle works in an opposite fashion of how I want it to work, because in my mind, contraction means tension, but here it's opposite because physics. But we don't care about physics in med school. All right, so this slide is where vision actually starts to make decisions, and it's not just detecting light. So the retina isn't a passive camera. It's already processing contrast and patterns before anything even reaches the brain. So start with the overall flow. Light is going to enter the eye, and it's going to hit those photoreceptors, your rods and cones. And at the very back of the retina, that's where all those guys are going to be located. So these cells convert light into a neural signal. And from there, the signal moves forward to bipolar cells and then to ganglion cells. The axons of ganglion cells bundle together to form the optic nerve, which is what actually leaves the eye and carries visual information to the brain. So the pathway is photoreceptor, bipolar, ganglion, optic nerve. The key concept here is how bipolar cells split the signal into on and off pathways. Photoreceptors release glutamate in the dark, and light reduces glutamate release. That's the switch everything is built on. So on center, bipolar cells are inhibited by glutamate. So in the dark, they're suppressed. And when light reduces glutamate, they turn on. So in contrast, the off-center bipolar cells are activated by glutamate. So they're active in the dark and decrease activity when light hits it. Same input, opposite responses. That's how the retina immediately creates contrast. So ganglion cells mirror this organization. On-center ganglion cells receive input from on-bipolar cells, and off-center ganglion cells receive input from off-bipolar cells. So by the time signals leave the eye, you already have two parallel channels, one that detect increases in light and one that detect decreases in light. And this is the foundation of edge detection. Your brain doesn't just see brightness, it sees differences in brightness. And one subtle but high-yield point here, the retina is layered in a slightly counterintuitive way. Light passes through the ganglion and bipolar layers before hitting those photoreceptors. So then those signals travel back outward to the ganglion. So structurally, light signals move in opposite directions. So if you zoom out, the takeaway is this. The retina is already doing pre-processing. It converts light signals, it turns light into signals, and it splits those signals into on and off channels. And the reason these on and off channels exist is they exist to enhance contrast before anything ever reaches the visual cortex. So by the time information leaves via the optic nerve, it's not raw data anymore. It's not just signals coming in through the brain. It's already edited and it's clean, and you already have a good idea of what you're looking at. All right, so this slide is about the background operators of the retina, the cells that don't carry the main signal forward, but shape it, refine it, and keep the whole system alive. So starting with horizontal cells, these sit between photoreceptors and bipolar cells and create lateral communication. Instead of signals moving straight down the chain, horizontal cells allow neighboring photoreceptors to influence each other. Functionally, they adjust neurotransmitter release from photoreceptors, which sharpen contrast. So this is the cellular basis of lateral inhibition. Bright areas suppress their neighbors, making edges more distinct. So when you see a crisp boundary between light and dark, that means horizontal cells are doing a lot of the work behind the scenes there. Amacrine cells operate one layer deeper between bipolar and ganglion cells, and they're more variable and less cleanly organized, but the high-yield concept is modulation over time. They help shape how signals change, not just whether they're on or off. So this makes them important for motion detecting and timing, detecting flickering, direction, rapid changes in light. If bipolar cells set up the signal, amacrine cells kind of edit the tempo. So Mueller cells are the structural and metabolic backbone of the retina. They span almost the entire thickness of the retinal cells and act like scaffolding. They regulate the extracellular environment by buffering ions, recycling neurotransmitters, and clearing waste. They also provide metabolic support to neurons and, interestingly, also help guide light through the retina with minimal scattering. So almost like fiber optic cables directing photons to photoreceptors. So if neurons are the processors, Mueller cells are the infrastructure that keep them functional. And then finally, you have the retinal pigment epithelium, or the RPE, and this is critical for photoreceptor survival. It contains melanin, which absorbs excess light and prevents internal reflections that would blur your vision. Its microvilli interdigitate with photoreceptors of our system, physically supporting them and participating in the visual cycle. It also does phagocytosis and recycles the discs from photoreceptors, which are constantly being renewed. So without the RPE, retinal pigment epithelium, photoreceptors rapidly degenerate. So the big picture takeaway is that vision isn't just a straight pipeline, right? These supporting cells introduce contrast, timing, stability, and maintenance. Without them, the main receptor, to bipolar cells to ganglion pathway would technically exist, but the signal would be noisy, it would be blurry, and it would be incredibly short-lived. All right, so this is the slide where photoreceptors stop being just rods and cones and turn into actual mechanisms to memorize. Yippee! Oh, yippee, I love memorization. Yippee! So start with a big functional split, right? So rods are going to be built for sensitivity, okay? And they detect low levels of light, which is why they dominate night vision and peripheral vision. The trade-off is for poor resolution and no color. I like to think of them as just like a night vision camera, right? Like night vision cameras always have like shitty resolution and they never really capture everything, but you have a good idea of what's going on. Those are your rods. There's a 20-to-1 rod to cone ratio, meaning most of your retina is optimized for detecting light and not detail. And when rods go down, patients lose night vision first, and then their peripheral fields start to collapse. Cones are the opposite, and the way I like to remember them is ice cream cones, which are multicolored, right? There's multiple flavors of ice cream, so cones are required for color. They give you that high acuity, okay? So they're densely packed in the fovea, which is why the central vision is sharp, okay? Damage here hits you really hard. You get the loss of cones, which means loss of detailed central vision, which is what legal blindness is usually reflecting. Now shifting to structures because this is where test questions like to come in. So the inner segment is basically the factory, okay? It's packed with organelles and it is responsible for producing photopigments. The outer segment is the business end. It contains stacked membranous discs loaded with photopigment, rhodopsin in the rods, iodopsin in the cones, okay? And this is where light actually gets converted into a signal. Those discs are constantly being shed and replaced, which is why the retinal pigment epithelium is essential for recycling them. The key biochemical idea is the role of 11-cis retinol. This is a vitamin A-derived chromophore that sits inside the photopigment. So when light hits it, it changes its shape to all-trans retinol, and that conformational change is what triggers the phototransduction cascade. So no vitamin A, no 11-cis retinol, and suddenly rods can't function properly, hence night blindness showing up in early vitamin A deficiency. Now the part people get tripped up on. So photoreceptors are depolarized in the dark, okay? And that's easy to remember because of the double D, right? Depolarized, dark. There you go. In darkness, cGMP levels are high, which means cGMP-gated sodium ion channels open, okay? Sodium flows in, maintaining a relatively depolarized state. And the cell continuously releases glutamate, because remember, glutamate lights the dark, okay? When light eventually hits it, it activates the cascade that will lower cGMP, and those sodium channels close. This is our hyperpolarization. So light doesn't activate photoreceptors, it actually reduces their activity. And so the signal is essentially a drop in glutamate release. The way I like to make this make sense in my brain is photoreceptors are for detecting light. So you are going to need them the most in an absence of light. You are looking for the light when there is not that much, right? So they're going to be super active in darkness. But when light actually comes in, They're like, oh shit, dude, you're good on light. We're got to inhibit some of this stuff. Okay? So I like to think of it as like a how much light do you need versus how much light do we have. All right, so this is the core mechanism you should really understand here, okay? So everything on this slide reduces to one principle, right? Light turns the signal off at the photoreceptor level. So start in baseline, right? Darkness. In the dark, cGMP levels are high, right? We are keeping those sodium channels open because cGMP is high, okay? Sodium flows into the photoreceptor, and because it's dark, we are depolarizing, and the cell continuously releases glutamate. Glutamate loves the dark. cGMP loves the dark. Everybody loves the dark because when it's dark, our eyes are like, we need any sort of visual information we can get, activate those photoreceptors. So this is the default state of a photoreceptor. It is active and releasing neurotransmitters in the dark. Now we introduce light. A photon hits rhodopsin and converts 11-cis-retinol to all-trans-retinol, okay? That structural change activates the opsin protein, which then will activate the G protein transducin. Transducin will then activate a phosphodiesterase, or PDE, and PDE breaks down that cGMP. So once cGMP levels drop, the sodium channels are no longer going to stay open, so they're going to close, and that stops the inward sodium current, and the cell becomes more negative, thus hyperpolarization. So darkness, depolarization, light, hyperpolarization. Here's the key consequence. Hyperpolarization means less glutamate release. So instead of sending a stronger signal, light actually reduces neurotransmitter output. The entire downstream system on and off bipolar cells is built to interpret that decrease. So a clean way to lock this in: dark, cGMP is high, the sodium channels are open, depolarized, glutamate on. Light, cGMP is low, channels closed, hyperpolarized, glutamate off. Clinically and conceptually, this matters because it explains everything downstream. On bipolar cells activate when glutamate drops, off bipolar cells deactivate, and contrast detection emerges from this push and pull system, okay? So light doesn't excite photoreceptors, right? It shuts them down, and the brain interprets that shutdown as vision. Really weird, but that's how it works. All right, so this slide is where everything you just learned about phototransduction and bipolar cells gets applied to how the retina detects contrast. So the key idea is that the retina is not trying to measure absolute brightness. It's trying to highlight differences. So a receptive field has two parts, a center and a surround, and they behave oppositely. So focus on the center first, because that's what the slide here is going to be isolating. So in the center, a cone detects light and adjusts glutamate release based on whether it's in the light or in the dark. So in the light, the cone hyperpolarizes and releases less glutamate, and in darkness, it depolarizes and releases more glutamate. That part you already know. Now, layer in the bipolar cells. On-center bipolar cells are inhibited by glutamate, so when light hits the cone and glutamate decreases, the inhibition is removed on the on-bipolar cell, thus making it active. That signal then propagates to an on-center ganglion cell, which increases its firing. So light in the center increases firing in the on pathway. In contrast, off-center bipolar cells are activated by glutamate. So when light reduces glutamate, when light reduces glutamate, they lose activation and their downstream ganglion cells decrease firing. So same stimulus, opposite effects. So flip the condition to darkness and everything just reverses. So more glutamate is released, which suppresses on-center cells and activates off-center cells. So the system is always comparing increasing versus decreasing in light rather than just reporting light is present. So the reason this all matters is the amplification point that's mentioned on the slide. When the center sees something different from the surround, light in the center with darker surroundings or vice versa, the difference gets exaggerated. That's how edges pop out. A uniform field of light produces relatively little signal change, but a boundary produces a strong response. So the clean takeaway is this. On-center cells fire more when light hits the center. Off-center cells fire more when light leaves the center. And the entire system is designed to exaggerate contrast, not brightness. So here's our missing piece to the puzzle that we just covered. So this is going to explain why center surround receptive fields actually oppose each other. And the answer is horizontal cells. It's the mechanism that flips the signal. So start with what's happening in the surround. So the surrounding photoreceptors behave exactly like the center ones. Light causes less glutamate, dark, more glutamate. But instead of projecting directly to bipolar cells, they first feed into horizontal cells. Okay, so horizontal cells integrate input from multiple surrounding photoreceptors and then send inhibitory feedback using GABA back onto the central photoreceptor terminals. That's the key move here. They don't just pass information forward, they modulate what the center photoreceptor is releasing. So now walk through that classic scenario. If light hits the surround, these photoreceptors, cones, are going to hyperpolarize and release less glutamate. That means the horizontal cell is less activated, so it releases less GABA onto the center photoreceptor. Less inhibition on the center means the center photoreceptor becomes relatively more depolarized or active and releases more glutamate, even if no light directly hit it. So that increased glutamate then suppresses on bipolar cells and activates off-center pathways. Flip it, if the surround is dark, those cones release more glutamate, right? Strongly activating the horizontal cell. The horizontal cell will then release more GABA onto that center photoreceptor, suppressing its glutamate release. Now, the center behaves as if it's in light, favoring on-center activation. So the surround is always doing the opposite of the center because it's indirectly controlling the center through inhibition. It's almost like the cerebellum for vision. So that's the entire point of lateral inhibition. The payoff is contrast enhancement. If both center and surround were equally lit, the opposing influences cancel out and the signal is weak. But if the center and surround differ, so light center with dark surround or vice versa, the system exaggerates that difference. And that's how edges become sharply defined. So the clean takeaway is this. Horizontal cells use GABA-mediated lateral inhibition to invert the surround signal, creating the center-surround opposition that lets the retina detect contrast instead of just light intensity. Okay, so vision can be very easily complicated, or overcomplicated rather. I like to break this down very, very monkey mode style, okay? So this is going to be vision in a nutshell, all right? So one thing you need to remember is that optic fibers are going to be flipped in their wording. And here's the clean version you should lock in. So each visual field is seen by both eyes, but different halves of each retina. So the left visual field hits the right half of both retinas. That means that the nasal retina, okay, of the left eye and the temporal retina of the right eye. Then, at the optic chiasm, nasal fibers cross and temporal fibers stay ipsilateral. So don't forget that nasal crosses, temporal stays, okay? That's why everything ends up contralaterally. So the left visual field goes to the right brain, and the right visual field goes to the left brain. After the chiasm, those bundles are called optic tracts. And each tract now carries information from one visual field, not one eye, okay? So from there, most fibers synapse in the lateral geniculate nucleus, or the lagoon, okay? You see a lagoon, okay, of the thalamus, all right? So think of the LGN as the relay station that organizes and refines the signal before sending it to the primary visual cortex in the occipital lobe. Now tie it back to function. The brain doesn't care about left eye versus right eye. It cares about left space versus right space. And that's why the system is wired the way it is. It combines input from both eyes into a single visual representation of each half of the visual world. So if you want a fast check, right, lesion before the chiasm is going to affect one eye, okay? It's just going to affect whatever those nerves are coming or are going to that eye. So if it's the right optic fibers, it's going to affect only the right eye. A lesion at the chiasm will affect crossing nasal fibers, because remember, nasal guys are the only guys that will decussate. They're the only ones that will cross, and that will cause bitemporal hemianopia. And we'll go through all the visual deficits, so do not worry about all the fancy terminology. A lesion after the chiasm will only affect one visual field, right? Because then those optic tracts are only carrying one visual field. Your left optic tract is carrying your right visual field, and your right optic tract is carrying your left visual field, okay? So if you have a lesion after that chiasm, it will cause contralateral homonymous hemianopia, okay? So it's pretty simple when you break it down, but it's easy to get mixed up. But just remember that nasal fibers are the ones that cross, temporal fibers do not, and each hemisphere processes the opposite visual field, okay? I don't know why I said okay so intensely. I mean, you just know that, you know? Sorry, I need to be more supportive. Man, that was intense. All right, so this slide is where the visual pathway becomes spatially organized, and if you don't slow down here, it turns into pure memorization instead of just monkey mode logic, and we like monkey mode here at MooseMed. So start with the big picture. After the lateral geniculate nucleus, or the lagoon, or the LGN, right? It signals travel to the occipital lobe via the optic radiations. And this is the geniculocalcarine pathway. From this point on, you are no longer thinking about eyes. You are thinking about visual fields mapped onto the cortex. So here's the key rule. The image is inverted, okay? The superior visual field projects onto the inferior retina, and the inferior visual field projects on the superior retina. It's just like our left visual field and our right visual field projecting onto the opposite sides of the retina. It's the same thing. So that inversion is why everything feels a little bit backwards from here on out. So from the lateral geniculate nucleus, the fibers split into two major roots. You have the inferior fibers, which come from the inferior retina and therefore carry superior visual field information. And they're going to sweep forward into the temporal lobe as Meyer's loop. So these fibers then loop back and terminate in the lingual gyrus, which sits below the calcarine fissure. So inferior pathway, temporal lobe, superior visual field, lingual gyrus. Okay? The superior fibers come from the superior retina and carry inferior visual field. These take a more direct route through the parietal lobe, and these are often called Baum's loop, and they terminate in the cuneus gyrus, which sits above the calcarine fissure. So the organization is clean if you phrase it right. So temporal loop, or Meyer's loop, is the superior visual field, and the parietal loop, or Baum's loop, is the inferior visual field. And the way I remember that is your bum is inferior. So when you're looking at your bum, you're looking at the inferior visual stuff. So that's how you remember that Baum's loop is the inferior visual field. And then Meyer's, just through process of elimination, superior. Now apply that to lesions, because that's where things start to get tested, and a lesion in the temporal lobe knocks out Meyer's loop. So if you lose the contralateral superior visual field, it's going to cause the classic pie in the sky deficit, which we'll break down in the following slide. So don't worry about visualizing that just yet. I just want to make you start thinking about these things. A lesion in the parietal lobe hits the superior radiations. So you lose that contralateral inferior visual field, and that's going to be that pie on the floor. So the example on the slide is exactly the logic in action. So if you damage the left inferior optic radiation, Meyer's loop, you're going to lose the right superior visual field. And so basically the big takeaway here is just remember the relationships here, right? So inferior pathway, all right, is going to give you superior vision. Superior pathway is going to give you inferior vision. And you can remember that another way to remember if the Baum's loop, I like to work my way back. I just remember that Baum's is inferior visual field because you bum. So that has to be a superior pathway, right? Since you're seeing the inferior visual field. I just remember it's opposite. So it's got to be a superior pathway. And what's one of the topmost portions of your brain? The parietal lobe. So the superior pathway goes to the superior portion of your brain, aka the parietal lobe. And just remember that the inferior one goes to the temporal. Okay? All right, so here's the slide about lesions, all right? This is going to be the big payoff for everything we just learned. So start at the optic nerve, right? This is pretty simple, right? This is pre-chiasm, so all the visual information from one eye is still bundled together. If you cut the optic nerve, you wipe out all vision from that eye. There's no tricks, there's no swaps here, it's just you're blind in that one eye. So now move to the optic chiasm. This is where things start to get a little interesting. Remember that the nasal retinal fibers cross, and those nasal fibers carry the temporal visual field, okay? So when something like a pituitary tumor compresses the chiasm, which is one of the most common reasons a chiasm gets compressed, it hits those crossing nasal fibers first. And that's going to result in a loss of peripheral vision in both eyes, which gives you what's called bitemporal hemianopia, aka tunnel vision. So patients can see straight ahead but lose everything on the sides, like walking around with blinders on. Once you're past the chiasm, everything is organized by visual field and not eye. So that means that lesions now affect both eyes in the same visual field. This is why we call it homonymous loss. So now tie in the radiations to what you just learned. A lesion in the superior optic radiation, or the parietal lobe or Baum's loop, right? Interchangeable there. Parietal lobe is more general, but Baum's loop, right? Knocks out the inferior visual field on the opposite side of that lesion. That's your pie on the floor. So left parietal damage, right lower quadrant gone in both eyes. A lesion in the inferior optic radiations, which goes to the temporal lobe, also known as Meyer's loop, knocks out the superior visual field on the opposite side. And that's going to be your pie in the sky. So left temporal damage, right upper quadrant gone. Okay? So the pattern to anchor this: pre-chiasm, one eye; chiasm, your peripheral vision is going to be gone; and post-chiasm, it's going to be same side visual field deficit in both eyes, okay? So this slide is where anatomy turns into stroke questions. So start at the retina and optic nerve outside the skull. So these are supplied by the ophthalmic artery, which we covered in our blood supply to the eye. And this is going to come off that internal carotid. Okay, clinically, this is where you get things like central retinal artery occlusion, which will cause sudden, painless monocular vision loss, and that's going to be a pre-chiasm vascular hit. So it behaves just like an optic nerve lesion because one eye is going to go dark. All right. Once you move intracranial to the optic nerve in the chiasm, the blood supply becomes a network, which is going to be the anterior cerebral artery, or the ACA. It's going to be your anterior communicating artery and the hypophyseal branches. And this is why aneurysms or pituitary tumors here don't just compress structures, they can also compromise blood flow. The pattern still tracks with what you just learned, but damage here tends to give bitemporal hemianopia because the crossing nasal fibers, again, are vulnerable to both structurally and vascularly. And remember, they carry the temporal visual field, okay? So you're going to get that tunnel vision. At the lateral geniculate nucleus, right, the lagoon, we see the lagoon, the supply shifts to the anterior and posterior choroidal arteries, okay? This area is less commonly tested in isolation, but when it is, you want to think of it as a relay station, okay? Lesions here give contralateral homonymous visual deficits, often with slightly messy or incomplete patterns because multiple small vessels are involved. So now we have the high yield part, which is going to be optic radiations. And these run through large chunks of the brain, so they're supplied by both MCA and PCA territories. And that's why strokes here are common and variable. So MCA strokes tend to hit lateral portions, including Meyer's loop, because remember, that's where that terminates, right? That's where our inferior tracts that carry our superior visual field terminate in the temporal lobe. And that's going to give you that pie in the sky deficit. While parietal involvement gives that pie on the floor, right? Because parietal is going to receive our Baum's loop, which is looking at our bum, aka our inferior visual field. So finally, the primary visual cortex, the occipital lobe, is supplied by the posterior cerebral artery, the PCA. A PCA stroke gives you a contralateral homonymous hemianopia. The classic twist here is macular sparing, okay? That's your buzzword here, okay? If you hear this, I want you to think PCA stroke. If you hear macular sparing, I need it to trigger you like a sleeper agent buzzword, okay? So macular sparing means PCA stroke because the macula often has dual supply from the middle cerebral artery, okay? So patients lose most of their visual field, but keep central vision, which is counterintuitive unless you remember that backup blood supply, okay? So the shortcut here is going to be ophthalmic is to eye and optic nerve, so that's going to cause monocular loss because you're still affecting that one eye. ACA, anterior communicating, hypophyseal, that's going to affect the chiasm, and that will cause your bitemporal hemianopia. You have MCA, PCA strokes, and that's going to affect your radiations, your optic radiations, so you're going to get those quadrant defects, like pie in the sky, pie on the floor. Then you're going to have PCA, cortex, and that's going to be your homonymous hemianopia, macular sparing, all right? I don't want anyone missing this on the exam if it shows up. If it does, you just killed like 6 moose, and that's completely on you. Here's just a big overall map to translate location to visual defect and to finally the likely cause. So starting with A, an ipsilateral scotoma, and this is a small localized retinal or optic nerve issue, often central. So think of it as a spot missing rather than full field loss, okay? It stays in one eye because you're still pre-chiasm, okay? Then we have B, which is going to be our optic nerve lesion. And this is the cleanest pattern in the whole pathway, right? If you just cut that nerve to that eye, you're going to get loss of vision in that one eye. Then we move on to C, optic chiasm. This is honestly, boards love the optic chiasm just because of this crossing of nasal fibers that are going to be hit. So you're going to lose that temporal vision. So bilaterally, and you're going to get bitemporal hemianopia, aka tunnel vision, okay? Once you pass the chiasm, you're going to get D, G, and H lesions. And this is where everything becomes contralateral and homonymous. So that means that the same side of the visual field is gone in both eyes, okay? So a right-sided lesion anywhere here is going to result in left visual field loss in both eyes, okay? That is the post-chiasm rule. Deficit, reflect, visual field, and not eye. Now, refine it with the radiations. We have E and J, okay? So that's going to be your Meyer's loop to the temporal lobe, and these carry the superior visual field. So lesions here give that contralateral superior quadranopia, your classic pie in the sky. So temporal lobe stroke, tumor, or surgery complication, you want to be thinking Meyer's, right? F and I are going to be Baum's loop, right, on the parietal lobe. All right, so these carry the inferior visual field. So lesions give contralateral inferior quadranopia or pie on the floor, which is because of that parietal involvement, you're going to have that lower quadrant gone. And finally, K, we have our occipital cortex, our PCA artery, which is going to give you that contralateral homonymous hemianopia, but again, that buzzword, macular sparing, okay? Macular sparing, seriously. The center of vision is preserved because it often has dual blood supply, okay? PCA and MCA. If you see hemianopia with that macular sparing, PCA. All right, wonderful. All right, so we are kind of going back to eye movement here, and this is just kind of to tie all the topics kind of together. And so if you can remember the function of our muscles, right? We have of our extraocular muscles, okay? So we have the lateral rectus controlled by abducens. We have superior oblique controlled by cranial nerve 4, and then all the rest are going to be 3. Okay, so the lateral rectus here is going to abduct the eye, and again is innervated by cranial nerve 6. And this nerve, again, is the backbone of horizontal gaze. That's a little teaser there. We're about to transition into that, so lock in. Because it also coordinates with opposite eye movement through brainstem connections, which we will go into. But basically, when cranial nerve 6 is out, the affected eye can't abduct. So it gets pulled medially and by the unopposed medial rectus. Clinically, that's medial deviation and horizontal diplopia that worsens when looking toward the effective side. Now, the weird one. We have superior oblique, which again is controlled by trochlear. Okay, this muscle's job is subtle but very testable. It depresses the eye when it's adducted, okay, adducted, and also intorts it. So cranial nerve 4, or trochlear nerve, is unique because it decussates before it leaves the brainstem. So the nucleus controls the contralateral eye. When it's damaged, the eye can't depress properly in adduction. So patients get vertical diplopia. The classic compensation is the head tilt again from the lesion to realign vision. So if you see someone tilting their head to fix double vision, that's going to be your cranial nerve 4. Everything else falls under cranial nerve 3, right? So that's doing most of the work. It controls most of the extraocular muscles, which are going to be your medial rectus, your superior rectus, your inferior rectus, and inferior oblique, and also levator palpebrae superioris, the LPS that keeps your eyelid open. So on top of that, it carries parasympathetic fibers for pupil constriction. So when cranial nerve 3 goes down, you get a very characteristic picture of the eye is down and out because lateral rectus and superior oblique are unopposed. So the eyelid is drooped, and you get ptosis, and the pupil is often dilated due to that loss of parasympathetics. All right, so this here is going to be the circuitry that explains why both eyes are going to be moving together, okay? Horizontal gaze, right? And why lesions here give very specific patterns. So this all starts at the frontal eye fields, the FEF, okay? These sit in the cortex and drive voluntary gaze to the opposite side. So the left frontal eye field makes you look right, and it does this by sending a signal down the contralateral PPRF in the caudal pons, okay? The PPRF, or the paramedian pontine reticular formation, if you want to use the full legal, is the actual horizontal gaze center, okay? So think of it as the command hub that says, okay, both eyes move in this direction now, and once that's activated, the PPRF sends signals to the ipsilateral abducens nucleus, okay? So now the abducens nucleus does two things at once. First, it activates the ipsilateral rectus muscle, right, to abduct the eye. That's nothing new. We knew that. Second, and this is the new thing here, it's going to send a signal through the MLF, the medial longitudinal fasciculus, or as I like to call it, the MILF, okay? So and it's going to use the MILF to talk to the contralateral ocular motor nucleus, cranial nerve 3. And that's going to activate the medial rectus of the opposite eye, and now both eyes are going to move together in the same direction. So, to put it in one clean line, it's going to be left cortex, right PPRF, and again, this is under the assumption that the left frontal eye field, right, is going to be kicking this off. So this is why we're starting in the left cortex, okay? So left frontal eye field, okay, it's going to go to the right PPRF, then that's going to go to the right cranial nerve 6, okay? And that's going to cause the right eye to abduct. And then also, it's going to tell the left cranial nerve 3 at the same time via the MILF, okay, to use that medial rectus to adduct the eye. And so both eyes are thus going to look to the right. Okay, this is why a lesion here is very testable. If the PPRF or abducens nucleus is damaged, you lose the ability to look toward the side with either eye. A conjugate gaze palsy is what that's called. If the MLF is damaged, you get internuclear ophthalmeglia, or INO. And the abducting eyes are going to be working, but the adducting of the eyes fails because there's no communication there. So the entire point of the system is synchronization, right? One command, two eyes, same direction. When it breaks, that pattern tells you what broke and where. And it's really easy to look at these systems as two separate things, right? With abduction, adduction. Remember, all this is happening at once, right? So that's why, I'm trying to build this picture of synchronization here. And the reason I like to think of the MLF as like the MILF is because when you see a MILF, you look, right? So you're going to use the MLF for your visual synchronization, right? When you see a MILF cross the street, you are using your horizontal gaze to be like, wow, that is a beautiful woman. And to add on to this horrible analogy that will probably get me in trouble, but here at MooseMed, we don't do things by the book. You can remember that the PPRF is in charge of that horizontal gaze as well, because when you first see that MILF, before it's even registered in your brain that it's a MILF, but you're like, wow, that's a beautiful person, you're going to go, which is kind of the sound that the PPRF makes. So first, you're going to go, and then you're going to see the MILF, or, use the MILF in your brain to coordinate that horizontal gaze. All right, and here we're getting into a clinical correlation of all this. So nystagmus looks dramatic, but it's actually a pretty weak localizer on its own. But so you don't necessarily want to anchor this diagnosis without its context. So what you're seeing is rhythmic oscillation with a slow drift and a fast corrective phase, which sounds like a lot of jargon. but let's break it down. So by convention, we name the nystagmus by the fast phase, okay? But clinically, the slow phase is what reflects the underlying deficit. So that's what can be a little bit misleading about this. So basically, all nystagmus is when when one eye starts to really jitter like crazy. It goes going back and forth real fast. So in horizontal gaze lesions, the key idea is imbalance. One side of the gaze system is underperforming, so the intact side pulls the eye, and the eyes drift towards the weak side or slow phase, then snap back in the fast phase. And because of that, the intact side often shows the nystagmus, even though the lesion is on the opposite one. Okay, so if you're trying to localize it, don't chase the eye that's moving more. Instead, look for the eye that can't perform the intended movement. That's the side of the lesion. The nystagmus is just the system trying to compensate for that asymmetry. And the way I like to think about it is the whole way, and we get into the nitty-gritty of this pathway later on, so I don't want to over-explain it too much here, but basically, abducens, right, is like, hey, we're going to be abducting. I'm going to be abducting one of these eyes. And to make sure that, you're not a chameleon and that both eyes move in that direction, it's got to talk to that cranial nerve 3, right? So what happens in nystagmus is basically the MLF is either damaged or something with the abducens is damaged, but the core point is that there's no conversation happening between the two eyes. And so one of the eyes is basically tweaking out and going like, Jesus, take the wheel, dude. I have no instructions. I'm just going to guess where the other eye is. So it starts rapidly moving, right? But that's why we don't necessarily want to focus on the eye that's moving as the side of the issue, okay? It's just the guy that has no instructions. He's doing that because he's not talking to the other eye anymore. Whereas the other eye is the problem child because he's not sending instructions to the other eye to move. So anyway, that's how I like to see nystagmus. And the actor that's actually on here, the random man on the slide here, is actually an actor named Pruitt Taylor Vince. But you can look up a clip from the most recent Superman from 2025, directed by James Gunn. And because I got to tie everything back to movies. I love movies, if you couldn't tell. But basically, there's a great scene if you just look up Pa Kent scene Superman. And it's a scene where Superman is going back to visit his foster parents, and he's sitting on the front steps with his dad, played by this actor, and they do a close-up of his face, and he has insane nystagmus. And it was really funny because when I was watching this movie, I didn't know about nystagmus at the time, but when I learned about it, I retroactively was like, oh my gosh, his MLF is probably messed up, or something's messed up, that's causing that. Not necessarily the MLF, but that communication pathway is disrupted. All right, so this is one of the most clinically useful reflexes because it tells you if the brainstem is working. The vestibulo-ocular reflex, or VOR, exists to keep your vision stable when your head moves. So if your head turns one way, your eyes are going to automatically move in the opposite direction so you can keep looking at that same target. That's why when you read a sign while walking or turning your head, nothing's going to blur, right? So the pathway is fast and mostly subcortical, meaning it's not going to involve that cortex. Motion is detected by the semicircular canals, which send signals to the vestibular nuclei of the brainstem. From there, the signal travels through the MLF, okay, to coordinate eye movement nuclei. So whenever you see the MLF, I just want you to think about coordinating eye movements, okay? And multiple things are going to use the MLF, but it's always to talk to your eyes. It always has to do something with visual coordination, okay? So going back to where we're at, the vestibular nuclei will then activate the ipsilateral cranial nerve 6, okay, which is then going to move that lateral rectus and at the same time send the signal through the MLF to the contralateral cranial nerve 3, which is what we've been talking about. And that's going to activate the medial rectus. And so this is going to be the same wiring you saw in the horizontal gaze. It's just triggered by head movement instead of you actually thinking about it, okay? So if you turn your head to the left, the system activates the rightward gaze circuitry, and your eyes move right to compensate. It's automatic, and it doesn't require conscious input. Clinically, this is what you're testing when things like the head impulse test, or even in comatose patients with the doll's eyes maneuver. If you're not familiar with those, I recommend looking them up. They're pretty interesting. So if the brainstem is intact, the eyes will move opposite to the head. If they move with the head instead, that's a bad sign. That means your VOR, or your vestibular ocular reflex, is not functioning. Okay, so big takeaway here. VOR, vestibular input, hijacks that horizontal gaze system to make sure that your vision is stable when you're moving your head. Okay, if it's intact, that means brainstem circuitry a la PPRF, your MLF, your cranial nerve 3 and 6 are working. If it's gone, you want to be thinking brainstem lesion, not just cortical. All right, so this is the vertical version of what you just learned for horizontal gaze, but it's a little less intuitive and unfortunately more testable because of that. So the vertical gaze center lives in the midbrain, not the pons, okay? And I find that pretty easy to remember because remember that the PPRF, or the is responsible for horizontal gaze, and part of that PPRF acronym is pontine, pons, okay? So I just remember that the vertical gaze one is higher in the midbrain. So the main driver for vertical saccades, which just means rapid eye movement between two fixed points, is the RIMLF, the rostral interstitial nucleus of the MLF. Okay, so it's just a different MLF. It's the RE-MLF. Okay, this structure generates the command for up and down eye movements. The asymmetry here is key. So upward gaze requires bilateral coordination, while downward gaze is more unilateral. And that's why lesions often hit upward gaze first, because it's more of a fragile system. Okay? So right next to it is the nucleus of Cajal, which doesn't initiate movement, but instead holds the eyes in a vertical position once they get there. So think of RE-MLF as the, hey, let's move, and then Cajal is going, cahold, bro. I need you to cahold that position right there. So when both functions are bundled together, you will see them termed RINC, which is just essentially the integrated vertical gaze control system. It's both of them in one. The posterior commissure is critical for upward gaze because that's where those fibers cross, okay? If you damage this area, you will lose the ability to look up. This is why dorsal midbrain lesions classically cause up gaze palsy. Now, tie in the pretectal area. This region integrates the pupillary light reflex and sits right in the same neighborhood, sending fibers through the posterior commissure. So lesions here also often affect both vertical gaze and pupil responses, which is a big clinical clue here. So, put it all together with pathology. Pineal tumors sit right on top of this system and compress the dorsal midbrain. That produces what we call Peyronie's syndrome, which we'll get into later, but here's a little teaser, which is very commonly associated with that pineal tumor. The classic triad includes upward gaze palsy, light near disassociation of the pupils, and convergence retraction nystagmus. Okay? So the mental structure is this, right? RE-MLF is for vertical movement. Cajal holds the position. Posterior commissure is for upward gaze, and pretectal is going to be pupils plus that nearby integration. Okay? So if someone can't look up, you want to be thinking dorsal midbrain, you want to be thinking pineal mass, and then you want to be thinking Peyronie's syndrome. All right, so this is one of those pathways where the sequence matters more than the details because every step is a possible lesion location. So starting at the top, you got sympathetic control of the eye begins in the hypothalamus and descends through the brainstem via the HRST, or the hypothalamic tract. Hypothalamospinal tract, that's my bad, HRST. These are the first order neurons, and they travel all the way down through the spinal cord to synapse in the intermediolateral cell column at T1 and T2. That's your preganglionic starting point. From there, second order preganglionic neurons exit the spinal cord through the ventral roots at T1 and T2 and enter the sympathetic chain and ascend. And this is important because it ascends up to that superior cervical ganglion, and that's where they're going to synapse. So now you're going to have third order postganglionic neurons take over, and these fibers are going to wrap around the internal carotid artery, forming the carotid plexus. And they're going to ride that into the skull through the carotid canal and cavernous sinus region. From there, they distribute into the orbit, largely hitchhiking on branches of V1. So their targets are straightforward but high yield. We've reviewed them before, but now we're just adding more of these neuropathways. It's going to be the dilator pupillae muscle for pupil dilation and superior tarsal muscle assisting in that elevation of the eyelids. So sympathetic, right? You're going to have those big wide open eyes. Remember, think drugs. Oh my God! So now flip it clinically. If you lose this pathway anywhere along the chain, you get Horner syndrome, which will lead to meiosis, which is loss of dilation, ptosis, loss of superior tarsal tone, and often anhidrosis, depending on where the lesion is. So the key is that this is a 3-neuron pathway. So lesions can be central in the brainstem, preganglionic, or postganglionic. So the clean mental note is hypothalamus, HRST, T1 to T2, sympathetic chain, SCG, okay, which is that superior cervical ganglion, ICA plexus, orbit, dilate the pupil and lift the eyelid. If the eye looks small and sleepy, that means the sympathetic output is kaput. It is gone. All right, and so here is just the one slide allocated to Horner syndrome. And again, that's no sympathetic, so it's going to be damage to that HRST, to the intermediolateral cell column, sympathetic chain, superior cervical ganglion, literally anything involved in the sympathetic pathway. And so again, the symptoms you want to look out for are going to be that meiosis, okay, which is going to be that constriction of the pupils. It's going to be ptosis, that slight droop there, and anhidrosis, okay, which is going to be loss of sweating. All right, so this slide is going to be testing whether you actually understand why the pupillary light reflex is bilateral and how the parasympathetic pathway is organized. So we're going to start with the key distinction here. This pathway does not go through the lateral geniculate nucleus, okay, which is normally involved in vision, okay? But remember that this is a reflex, okay? We don't care about cortex shit. This is all very local. So that's going to be a common trap. Just look out for it, right? If it's a reflex, it's just going to be super, super quick, okay? Visual perception goes to the lateral geniculate nucleus, but reflexes take the shortcut. So make them a reflex. So light hits the retina and travels through cranial nerve 2, the optic nerve, and instead of going to the lagoon, or the lateral geniculate nucleus, those fibers peel off and synapse in the pretectal area of the midbrain near the superior colliculus, which is responsible for our visual reflexes, okay? So this is your reflex integration center, right? So from the pretectal nucleus, the signal is split and sent bilaterally to both Ehninger-Westphal nuclei. Some fibers stay ipsilateral and some cross to the contralateral side. That's the entire reason one eye shining light causes both pupils to constrict. So you're activating both parasympathetic nuclei at once. So from each Ehninger-Westphal nucleus, preganglionic parasympathetic fibers travel with cranial nerve 3, ocular motor nerve, to the ciliary ganglion, and that's going to be your synapse point. Then the postganglionic fibers are going to leave that short ciliary nerve and go to the sphincter pupillae muscle, causing that constriction. So if you compress it down and you just need a little flow chart, it's going to be retina, cranial nerve 2, pretectal area, bilateral Ehninger-Westphal nuclei, cranial nerve 3, ciliary ganglion, short ciliary nerves, sphincter pupillae, finally constriction. And clinically, this is where localization becomes very powerful, because if shining a light in one eye doesn't cause the other pupil to constrict, the problem is afferent cranial nerve 2, because you're not getting that visual input. If both constrict when the other eye is stimulated, but not when that eye is stimulated directly, that's still afferent. If one pupil never constricts no matter what, that's efferent. So cranial nerve 3 or downstream parasympathetics, okay? So the bottom line here is the reflex is going to be pretectal plus that bilateral Ehninger-Westphal without involvement of that lateral geniculate nucleus. Okay, and here's some just quick lesion info, okay? So the key idea is fiber organization inside the ocular motor nerve. So not all fibers are going to be equally protected. So the central or inner fibers are mostly going to be somatic motor nerves. All right, these control extraocular muscles like our medial rectus, our superior rectus, etc. And these fibers are supplied by small internal blood vessels. So they're more vulnerable to ischemia, especially from things like diabetes. The peripheral or outer fibers are the parasympathetics coming from Ehninger-Westphal nucleus. and these control pupil constriction. Because they sit on the outside of the nerve, they're the first to get hit by compression issues, like the posterior communicating artery aneurysm. So clinically, this creates a very high yield pattern, right? If you have a diabetic ischemic cranial nerve 3 palsy, the pupil is usually spared. You see eye movement problems with that down and out presentation, but the pupil still constricts because the outer parasympathetic fibers are still intact. If you have a compressive lesion, right, so the pupil will be blown or dilated early, and that's because those outer parasympathetic fibers get crushed first. So you get mydriasis plus eye movement deficits. So the shortcut here is ischemia or diabetes will cause motor affected or in pupil spared, and then compression or like an aneurysm will cause pupil affected early. All right. And so tying it back to the slide, you're going to have inner fibers, which are going to be ischemia prone, and you're going to have outer fibers, which are going to be your parasympathetics again, and those are going to be compression prone. All right, and in this slide, we're going to get into the second parasympathetic pathway, and it's different from the light reflex in one critical way. It does involve the cortex. Okay, so it's not really a reflex. Accommodation is not really a reflex because it involves your cortex, but it's sometimes referred to that way. So start with the input. Visual information from the retina will travel through the standard visual pathway, which is going to be through our cranial nerve 2 to the optic chiasm, to our optic tract, to our lateral geniculate nucleus, then to the occipital cortex. Unlike the light reflex, this pathway does go through the lagoon or the LGN because this is a conscious process. You're deciding to focus on something close, okay? Once the visual cortex recognizes a near object, it sends signals forward to the midbrain, specifically to the pretectal area and Edinger-Westphal nucleus. From there, the parasympathetics pathway look pretty familiar, with preganglionic fibers traveling with cranial nerve 3 to the ciliary ganglion, then postganglionic fibers go via the short ciliary nerves to the ciliary muscle. So when the ciliary muscle contracts, it reduces that tension on the zonular fibers that are attached to our lens, allowing to the lens to become more rounded or ball-like, which increases refractive power for near vision. And again, the way I like to remember that, if the ball is close to your face, your lens will become more ball-like. But accommodation is just one thing, right? But it's a triad of things that make it high yield, which is going to be that lens thickening, which is done by that ciliary muscle, again, parasympathetics via cranial nerve 3. It's going to be pupillary constriction, right, which is going to be sphincter pupillae on that same pathway. You're going to have eye convergence, which is going to be your medial rectus muscle, which is going to be your somatic motor via cranial nerve 3. And so compared to the light reflex, remember, the light reflex is subcortical. It bypasses that lateral geniculate nucleus. But with accommodation, it's going to be cortical because it requires that visual cortex input. So the clinical tie-in here is if someone can constrict pupils to near objects but not to light, that's a light near a disassociation. So think neurosyphilis, right? That tells you the reflex pathway is probably broken, but the cortical accommodation pathway is intact. So the clean mental model is going to be visual cortex decides this is close. The signal is going to be sent to Edinger-Westphal nuclei. Then cranial nerve 3 will talk to the ciliary ganglion and ciliary muscle will contract, and then the lens will round, and then you're going to get constriction and convergence. So if the eye can't focus up close, you want to be thinking parasympathetic of cranial nerve 3 pathway or ciliary muscle problem. All right, so this is one of those straightforward conceptually, but shows up in tricky localization questions. So the corneal reflex is a protective brainstem reflex. So basically you touch your eye or the cornea and both eyes blink. The key is that it's bilateral, those both eyes, even though you're only stimulating one eye. So the sensory or afferent limb is going to be cranial nerve V1, specifically that nasociliary branch of the ophthalmic division of trigem. What a name. So that signal goes to the chief sensory nucleus of 5 in the pons. And from there, interneurons project bilaterally to both facial and motor nuclei. The motor, the efferent limb, is going to be your facial nerve or cranial nerve 7, which activates the orbicularis oculi muscles, causing both eyelids to close. So the pathway in one line is cornea, cranial nerve V1, sensory nucleus in the pons, bilateral connection, cranial nerve 7, orbicularis oculi, you're going to blink with both eyes. So now the clinical logic is going to be what's going to actually get tested here. So if you touch one cornea and neither eye blinks, the problem is the afferent limb, or cranial nerve V1, right, on that side, because the signal never even made it into the system. If you touch one cornea and only the opposite eye blinks, the afferent limb is intact, but the efferent limb, cranial nerve 7, on the side that you touched is damaged, so the eye can't close. So if you want a quick little way to remember it, right? No blink at all, it's going to be a V1 problem. One eye blinks, that's probably going to be a facial problem on the non-blinking side. So also note the level. So this reflex localizes to the pons. So if it's gone, you're thinking brainstem involvement or cranial nerve lesion, not cortex, okay? And make sure not to, this is just something that my professor brought up, but I'll just repeat it here because you never know. When doing the corneal reflex in practice, make sure that you are not jump scaring your patient by just not telling them that you're about to poke them in the eye, right? Because that will be a different reflex arc altogether, which is called the startle reflex and not the corneal reflex, okay? So just don't jump scare your patient. You'll be fine. All right, so once that visual information reaches V1, okay, that ophthalmic branch of your trigem, the brain splits it into two processing streams with very different jobs. So if you mix these up, lesion questions get pretty gross fast, so get this straight in your brain. So the dorsal stream projects from the occipital cortex up to the parietal lobe. This is the where or how pathway. It tells you where an object is in space and how to interact with it. It's tightly linked to motor planning, so when you reach for a mug and you orient your hand correctly to grab the handle, that's dorsal stream function. Damage here doesn't mean you can't see the mug. You can, but you'll struggle to use that visual info to guide your movement. You want to be thinking optic ataxia or spatial disorientation. The ventral stream projects from the occipital cortex to the temporal lobe, and that is the what pathway. It handles object identification, so shape, color, recognition, naming. This is how you know it's a mug and not a bowl, right? If this pathway is damaged, you can see the object and even reach for it correctly, but you can't identify it. So a classic example is called visual agnosia. And just the clean way to separate the two, right? So you have dorsal, which is going to go to the parietal. And if you think of our classic like dorsal ventral, right? If you think of your head as an isolated thing, right? The dorsal will be the top of your head, ventral will be going out to the bottom of the chin, right? So if it's the dorsal pathway, it's going all the way up to the parietal lobe, right? So that's going to be your where and how, and that's going to be spatial and action, right? Your ventral stream is going to be going to your temporal lobe, and that's going to be your what, which is identity and recognition. So you can reach out, you can see, you can grab the thing, but you can't necessarily name it. All right, so here we are now officially moving on to the pharynx and larynx side of things. So this slide is mostly anatomy, but the way to make it stick is to think of the pharynx as a shared hallway where air and food are temporarily in the same space. And the body has to manage that traffic without making you choke, right? So the pharynx runs from the base of the skull down to about C6, where it transitions into the esophagus. It's not purely digestive, it's also part of the respiratory tract, which is why coordination here matters so much. So the larynx sits anteriorly within this region, acting like the gatekeeper for your airway structures. So structurally, the pharynx is wrapped in layers. The buccopharyngeal fascia is the outer covering, and internally you have the pharyngobasilar fascia, which provides structural support where muscle is deficient. So you don't usually get tested on just the names. It's more about the relationships of stuff. So just know those borders. You know, buccopharyngeal on the outside and inside is pharyngobasilar. So then now breaking it up into three regions, because this is where a lot of the exam questions are going to come in. You have the nasopharynx, okay, and that's going to be the first part of your pharynx, and it's going to run from the skull base to the soft palate. And this is strictly airway. No food should be in here, right? This is in your nose. It connects the nasal cavity and contains the opening of the eustachian tube. So you want to be thinking pressure equalization and middle ear stuff, right? Then you have the orthopharynx, or the oropharynx. Sorry, I always like to say orthopharynx. It's oropharynx. And that goes from the soft palate to the epiglottis. And this is where air and food both pass, so it's already a shared zone. And this region includes the tonsils and is heavily involved in your immune defense. And then finally, we have the laryngopharynx, or the laryngopharynx, and this extends from the epiglottis down to the esophagus. And this is a critical decision point where food gets directed posteriorly into the esophagus while air moves anteriorly into the larynx. And this is where body starts to separate those two pathways during swallowing. So functionally, this whole system relies on precise coordination, and if that coordination fails due to a neurologic lesion or a muscle dysfunction, you get aspiration, which is a major clinical issue. Okay, so nasopharynx, air only, oropharynx, air and food, and the laryngopharynx, separation zone, okay? And the way I like to remember that the larynx is for talking and not, the separation of food is la 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 when you sing, right? Larynx, larynx, there you go, right? All right, now we're just going to break down each of those layers of the pharynx and give them their own slide. So the nasopharynx, again, is that air-only segment of the pharynx, and everything on the slide just is going to tie back to airflow, immune defense, and middle ear pressure regulation. So it extends from the base of the skull down to that soft palate, roughly around C1 to C2, and nothing you swallow should pass through here, right? If it does, that means something is wrong with the soft palate elevation, so you should be thinking like cranial nerve 10 issues, okay? So on the posterior wall, you have the pharyngeal tonsils, okay? The adenoids is what they're called. And sitting in the pharyngeal, and that they're going to be sitting in the pharyngeal recess. These are going to be part of what's called Walder's ring and act as an early immune checkpoint. Clinically, when these enlarge, especially in kids, they can obstruct airflow and contribute to mouth breathing, snoring, or recurrent infections. Laterally is one of the most important landmarks. You have what's called the torus tubarius, which is the mucosal elevation over the opening of the pharyngotympanic tube, okay? And this tube connects the nasopharynx to the middle ear and is responsible for pressure equalization. If this system doesn't work, like with inflammation or blockage, you get ear fullness or impaired hearing or otitis media. Just inferior to that, you have the mucosa, which forms folds related to the underlying muscles. You have the levator veli palatini, which creates the levator pad, and you have salpingopharyngeus muscle from the salpingopharyngeal fold and tube. And these muscles help open the auditory tube during swallowing, again, tying it back to that pressure regulation. All right, and now we're going to move on to the oropharynx, which is that middle portion of the pharynx, and it's extending from the soft palate down to the epiglottis, and it serves as a shared pathway for both food and air, right? So this makes it a critical transition zone where the body begins to coordinate swallowing while still maintaining an open airway. One of the most important anatomical features in the region is the oral fauces, which is an opening between the oral cavity and the oropharynx. So functionally, this is the passageway that food must move through after leaving the mouth, and it becomes clinically relevant in conditions affecting swallowing or airway protection. So the boundaries of the oral fauces are formed by the faucial pillars, which are composed of two arches. The anterior pillar, known as the palatoglossal arch, which contains palatoglossal muscle and helps elevate the posterior tongue while narrowing the opening of the oropharynx. And then you have the posterior pillar, or the palatopharyngeal arch, which contains the palatopharyngeal muscle, and it plays a role in elevating the pharynx during swallowing. So between these two pillars lies the palatine tonsil, which is part of our immune defense system and contributes to the first line of protection against inhaled or ingested pathogens. Clinically, the palatine tonsil is highly relevant because it is a common site for infections, such as in tonsillitis, and is closely associated with the glossopharyngeal nerve, or cranial nerve 9. This nerve provides sensory innervation to the tonsillar region, which explains why inflammation here can cause referred pain to the ear. Additionally, the tonsillar region is supplied by branches of the facial artery, making it a potential source of significant bleeding during procedures like a tonsillectomy. So the musculature of the oropharynx includes palatoglossus, palatopharyngeus, and salpingopharyngeus, and they work together to coordinate the early phases of swallowing. These muscles help elevate the pharynx, guide the bolus of food downward, and assist in closing off the nasopharynx to prevent regurgitation of food into your nose. So overall, the oropharynx functions as a highly coordinated junction where structural anatomy, neural control, and muscular activity integrate to ensure that safe and efficient passage of both food and air. All right, so the vallecular region is small but clinically important space because it's located between the base of the tongue and the epiglottis, and it's formed by three mucosal folds called the glossoepiglottic folds. One median fold in the center and two lateral folds on either side. These folds create two small depressions between them known as the epiglottic valleculae, and functionally the valleculae act as a temporary holding space during swallowing, which help guide the bolus of food around the epiglottis and towards the esophagus. So this region becomes especially relevant in patients with impaired swallowing, such as those with neurologic deficits or reduced coordination of the swallowing reflex. And in these cases, food or liquid can accumulate in the valleculae instead of being efficiently cleared. So if that material is not properly redirected, it can spill over into the epiglottis and enter the larynx, leading to aspiration. And this is why vallecular region is often often assessed in swallow studies and is a key anatomical site when evaluating aspiration risk. All right, so the laryngopharynx, or the laryngopharynx, is the most inferior portion of the pharynx, extending from the level of the epiglottis down to approximately C6, where it transitions into the esophagus. This region represents the final decision point for airflow and food passage. Air is directed anteriorly into the trachea, while food is directed posteriorly to the esophagus. And because of this, the laryngopharynx plays a critical role in protecting the airway during swallowing and ensuring that these two pathways remain functionally separate. Anatomically, the laryngopharynx lies posterior and lateral to the larynx, essentially wrapping around it. One of the most clinically important features is the piriform recess, a pair of pear-shaped depressions located on either side of the laryngeal inlet, and these recesses act as a channel that help guide food around the larynx during swallowing. However, these are very common sites where foreign objects, specifically fish bones, so if they come up in a vignette, that is your buzzword, can become lodged, okay? So this region is closely associated with the internal branch of the superior laryngeal nerve, which is usually the nerve that gets injured by a fishbone that penetrates that area. And it's going to provide sensory innervation above the vocal cords and pass through that piriform recess. So, like I said, as a result, injury or irritation of this area, such as from a lodged foreign body, can lead to pain, impaired sensation, or disruption of protective airway reflexes. So, clinically, this makes the laryngopharynx an important site to evaluate in cases of dysphagia, aspiration risk, or suspected upper airway obstruction. All right, so going back to the pharynx, we're going to start touching on the muscles here. So the muscles of the pharynx are organized into a coordinated system that drives swallowing, and there are 6 total muscles to know. Most of them are derived from pharyngeal arch 4 and are innervated by the vagus nerve, cranial nerve 10, via the pharyngeal plexus, with one key exception that's commonly tested. So functionally, these muscles are divided into 2 groups: the circular constrictor muscles, which propel the bolus of food downward, and the longitudinal muscles, which are going to elevate the pharynx. Focusing first on the 3 pharyngeal constrictors, we have the superior constrictor, the middle constrictor, and the inferior constrictor. These are arranged like stacked sleeves around the pharynx and contract sequentially during swallowing to push food toward the esophagus. All 3 constrictors insert posteriorly at the pharyngeal raphe, a midline fibrous seam that anchors the muscles and blends inferiorly into fascia of the esophagus. Despite their circular arrangement, they are not true sphincters, but rather sequential compressors that generate a peristaltic wave. Each constrictor has a distinct anatomical attachment that helps you differentiate them. So the superior constrictor attaches to structures near the base of the skull and the mandible, anchoring the upper portion of the pharynx. The middle constrictor attaches to that hyoid bone, forming the central muscle layer. And then the inferior constrictor is the most clinically significant because it's going to attach to that thyroid cartilage and the cricoid cartilage. The cricopharyngeus portion, or that cricoid cartilage portion, acts as the upper esophageal sphincter, regulating the passage of food into the esophagus and preventing air from entering the digestive tract. So clinically, dysfunction of the inferior constrictor, particularly the cricopharyngeus, can lead to swallowing disorders such as dysphagia or the formation of what's called Zenker's diverticulum, where increased pressure causes herniation of mucosa through a weak area into the posterior pharyngeal wall. Overall, the constrictor muscles are essential for generating that force and coordination required for moving that food through your mouth and down into your, or just through your pharynx, especially in that oropharynx region into the esophagus. All right, so the vertical or longitudinal pharyngeal muscles function differently from the constrictors. They don't push the bolus of food down, they actually elevate and shorten the pharynx during swallowing. And this elevation is critical because it helps the pharynx, quote unquote, meet the incoming bolus and facilitates smooth transfer into the esophagus. There are 3 of these muscles here. We have stylopharyngeus, salpingopharyngeus, and palatopharyngeus, and all of them insert onto the superior horn of the thyroid cartilage, anchoring their action to the laryngeal framework. So the stylopharyngeus is the most clinically important of the 3 because it's the only pharyngeal muscle not innervated by the vagus nerve. Instead, it is innervated by the glossopharyngeal nerve, reflecting its origin from pharyngeal arch 3. Whereas the other ones are arch 4 derivatives, right? So it originates. So stylopharyngeus is going to originate from the styloid process and functions to elevate and dilate the pharynx, making space for the bolus as it moves downward. The salpingopharyngeus is a relatively small muscle that originates from the cartilage of the auditory tube, and it is innervated by a vagus nerve and contributes to elevating the pharynx while also helping open the auditory tube during swallowing or yawning, which aids in pressure equalization in the middle ear. Then we have the palatopharyngeus, and it's the largest muscle of the group and originates from the hard and soft palate. It also receives innervation from vagus nerve and plays a minor role in elevating the pharynx and guiding the bolus downward, but it forms the posterior fascial pillar, making it both structurally and functionally important in coordinating that transition from the oral cavity into the pharynx. So overall, these longitudinal muscles work together to elevate that pharynx, widen the lumen, and coordinate that passage of food, and completing that downward propulsion generated by those constrictor muscles. So the pharyngeal gaps are regions of relative muscular deficiency between the pharyngeal constrictor muscles, and they are clinically important because they serve as a passageway for key neurovascular structures entering or exiting the pharynx. Rather than being some random weak spots, these gaps are organized and consistent, and each one consistently transmits specific structures, making them very testable. So the first gap is located between the base of the skull and the superior pharyngeal constrictor. The space allows structures associated with the nasopharynx to pass through, specifically the levator veli palatini muscle and pharyngotympanic tube. And functionally, this makes sense because both structures are involved in soft palate elevation and middle ear pressure regulation, which are tied to the uppermost portion of the pharynx. The second gap, found between the superior and middle constrictors, transmits the stylopharyngeus muscle and the glossopharyngeal nerve. This is a key relationship because remember, cranial nerve 9 innervates the stylopharyngeus, and both structures are entering through the same gap, which is going to reinforce that functional pairing. This region is also important clinically because cranial nerve 9 provides sensory information to the oropharynx and contributes to the gag reflex. The third gap, located between the middle and inferior constrictors, transmits the internal branch of the superior laryngeal nerve, along with the superior laryngeal artery. And these structures provide sensory innervation above the vocal cords and vascular supply to the larynx, making this gap important for airway sensation and protective reflexes. Finally, the fourth gap lies between the inferior constrictor and the esophagus, and this is where the recurrent laryngeal nerve and accompanying vessels pass. Because this nerve provides motor innervation to most of the intrinsic muscles of the larynx, pathology affecting this region, such as a surgical injury or compression, can result in hoarseness or vocal cord paralysis. Overall, the pharyngeal gaps can be understood as structure entry and exit points that maintain the functional connectivity between the pharynx, the larynx, and the surrounding neurovascular systems, which also representing potential sites of vulnerability in both disease and surgical intervention. All right, so the blood supply and innervation of the pharynx are relatively straightforward compared to the anatomy, but they are high yield because they tie directly into clinical reflexes and nerve lesions. So arterially, the pharynx is primarily supplied by branches of the external carotid system, most notably by the ascending pharyngeal artery, and contributes from the superior thyroid artery. These vessels provide a rich vascular network to support the muscular and mucosal layers involved in swallowing. Venous drainage occurs through the pharyngeal venous plexus, which ultimately drains into the internal jugular vein, making it clinically relevant for the spread of infection or deep neck space complications. Innervations is where the most testable material lies here. So sensory innervation of the pharynx, specifically general visceral afferent, so GVA, sensation, is carried primarily by the glossopharyngeal nerve, or cranial nerve 9, and this is especially important for detecting stimuli in the oropharynx and triggering protective reflexes. So motor innervation, including both branchial motor, SVE, and parasympathetic, GVEP, components, is provided mainly by the vagus nerve, cranial nerve 10, via the pharyngeal plexus. So there is one key exception that is almost always tested. The stylopharyngeus muscle, remember, is innervated by cranial nerve 9 and not 10. And this is going to, again, reflect that embryological origin difference. Sympathetic innervation, GVES, reaches the pharynx from the sympathetic chain, and it's going to be contributing to vascular tone and other autonomic functions rather than direct motor control of swallowing. Finally, the gag reflex ties all of this together clinically. The afferent limb, or the sensory limb, is going to be cranial nerve 9, which senses that stimulation of the posterior pharynx. And then the efferent limb is going to be cranial nerve 10, which activates the pharyngeal muscles to produce the gag response. And this reflex is commonly used in neurological exams to assess the integrity of these cranial nerves. Honestly, this one isn't too deep. All you have to know on this topic regarding lymph nodes of the pharyngeal region is going to be that retropharyngeal lymph nodes are going to be draining into those deep cervical lymph nodes. And that's kind of it. That's all that was really covered for my program. So that's all I'm putting here. So just remember that retropharyngeal is going to drain into that deep cervical. All right, so the larynx is best thought of as a controlled valve sitting inside the airway, which is why I called it here the tube within the tube. It belongs to the respiratory system, but its real importance is that it regulates airflow and converts that airflow into sound. So as air leaves the lungs, it passes through the larynx, where the vocal cords can adjust tension and open to control both the speed of the air and the vibration needed for phonation, or speaking. So structurally simple, but functionally super precise. Entry into the larynx occurs through the laryngeal inlets, okay, which is essentially like the gateway for the laryngopharynx into the larynx. So once you pass through that inlet, the first space you're going to encounter is called the vestibule. This is more of a protective region than a sound-producing one. The vestibular folds, also called the false vocal cords, sit here. They don't contribute to normal speech, which is why they're called false vocal cords, but play a role in protection and mucus production. Think of them as backup barriers and lubrication rather than instruments. Between the vestibular folds above and the true vocal cords below, or folds, is a small recess called the laryngeal ventricle. And it's just an outpouching, but clinically it matters because it allows some movement and spacing between these layers. Then you reach the true vocal cords, which are the main event. And these are mobile, tightly controlled structures composed of mucosa over the vocal ligament. These are responsible for essentially all phonation. And when they adduct and vibrate, you get sound. And when they abduct, you get airflow. Okay, so adduction and vibration, you're going to get sound. Abduction, you're going to get airflow. And I said vocal cords, they're called vocal folds, okay? Vocal cords is just, like that colloquial version of it. So the opening between the true vocal folds is called the rima glottidis, and it's the narrowest and most functionally important part of the airway in the larynx. Changes here directly control airflow and voice production. So between this region is the infraglottic space, which continues down to the trachea, and clinically, anything that narrows the rima glottidis, like edema, paralysis, or a mass, can significantly impact both breathing and speech, which is why this region is heavily emphasized. So just a clean model is going to be that inlet into the vestibule, which is going to be where you're going to find your false cords or your vestibular folds. Then you're going to go to the ventricle, and then true cords for phonation or true vocal folds. And then you're going to have the rima glottidis, which is to control airflow, and then you're going to have that infraglottic space all below that, and then you're going to be in the trachea. All right, so the larynx is built around a framework of 9 cartilages. And if you understand how they interact, the rest of the laryngeal function kind of becomes much easier to reason through. So the key division is into 3 large unpaired cartilages that form the structural scaffolding and 3 paired sets that are going to fine-tune movement, especially for phonation. So start with the big 3. The thyroid cartilage is the largest and forms the anterior wall of the larynx and what you feel as the Adam's apple. Its prominence in males is due to the angle between the laminae being more acute, which changes vocal cord tension and contributes to that deeper voice. Just posterior and inferior to that sits the cricoid cartilage, which is structurally unique because it forms a complete ring around the airway. Think of it like a little signet ring, narrows anteriorly and thickens posteriorly. That thick posterior plate is critical because it provides a stable base for those arytenoids to sit on. And it's also clinically important because this is the only rigid circumferential support in the airway system. So this is why it matters the most for airway management. The third unpaired cartilage is going to be the the epiglottis, which is more flexible and leaf-shaped. Its stalk anchors to the inner surface of the thyroid cartilage, and functionally, it's going to act as that protective flap, folding over the laryngeal inlet during swallowing to prevent aspiration. It's not a perfect seal, but it significantly redirects food away from the airway. Now shifting to the paired cartilages, which is where the real motion starts to happen. So the arytenoid cartilages are going to be sitting on top of the posterior cricoid, like two little pyramids, and they are the control knobs for vocal cords. Each has a vocal process anteriorly where the true vocal folds are going to attach, and a muscular process laterally for muscle attachment. And when these rotate or slide, they open and close the rima glottidis, and this is how you abduct or adduct the vocal cords. Perched on top of the arytenoids are the corniculate cartilages, and these are small nodules that essentially extend and reinforce their arytenoid apex. They don't do much independently, but they help maintain the shape of the posterior laryngeal inlet. Then you have your cuneiform cartilages, which are embedded within the aryepiglottic folds, and they don't articulate with the other cartilages, and instead they just act as structural support that keep the soft tissue of the laryngeal inlet from collapsing inward. So a clean way to think about it is going to be like your thyroid, your cricoid, and your epiglottis are going to be structure and protection. Your arytenoids are going to be movement and voice control. Corniculate and cuneiform are going to be your structural reinforcement. And if something goes wrong with your voice, you're usually thinking arytenoids and their muscles. If something goes wrong with airway patency or trauma, you want to be thinking cricoid or thyroid due to their structural support. All right, and now we're going to be getting into what actually turns the larynx from a pile of cartilage into a functional tube, and that's going to be the ligaments and membranes. And so a clean way to think about it is that extrinsic is going to be anchoring the larynx, whereas intrinsic are going to be shaping the airway and voice apparatus. The extrinsic ligaments connect the larynx to structures outside of it, so they basically stabilize and suspend it in the neck. The thyroid membrane connects the thyroid cartilage to the hyoid bone, acting like a flexible sheet that allows the larynx to move during swallowing while still staying tethered. And inferiorly, you have the cricotracheal ligament, which is going to connect that cricoid cartilage to the first tracheal ring, anchoring the larynx to the rest of the airway below. And then you have the hyoepiglottic ligament, which is going to connect the epiglottis to the hyoid bone, helping position the epiglottis so it can properly fold over the inlet during swallowing. And these are less about fine control and more about keeping everything aligned with allowing movement. The intrinsic membranes are where things are starting to get a little bit more interesting because they're going to connect those laryngeal cartilages to each other and actually define the internal architecture of the airway. There are two big players here, and they are essentially creating the upper and lower boundaries of the laryngeal tube. The first is going to be your quadrangular membrane, which is going to span from the epiglottis, or I always say epiglottis to the arytenoids. It's the superior edge of the aryepiglottic fold, which outlines the laryngeal inlet. Its inferior free edges form the vestibular ligament, which underlies the false vocal cords. So this membrane is basically responsible for building the upper protective layer of the larynx. Then you have the cricovocal membrane, also called conus elasticus, which runs from the cricoid cartilage up to the vocal process of the arytenoids. Its superior free edge thickens to form that vocal ligament, which is a structural core of true vocal folds, and this is the business end of phonation. Without this membrane, you don't have functional vocal folds. Okay, so if you want just a little tight mental framework here, you got quadrangular membrane is going to be your false vocal cords and inlet shaping for protection. Then you're going to have your conus elasticus, and that will be your true vocal folds and sound production for phonation. And everything else is just going to be support. All right. And this slide is just going to be showing you the functional positions of the vocal folds. And it's one of those things that becomes very intuitive once you stop thinking about anatomy and just start thinking about airflow control valves. So in the resting state during normal breathing, the vocal folds are slightly abducted, creating a narrow but open rima glottidis. Air moves quietly through without resistance, and this is your baseline. No effort, no sound production, just passive airflow. So when you move into forced respiration, the vocal folds abduct widely. The arytenoids rotate laterally, pulling the folds apart and creating a large space, a triangular opening. And this is the maximal airflow mode. Your body is prioritizing oxygen delivery, not sound. If someone can't do this, for example, bilateral recurrent laryngeal nerve injury, airway compromise becomes a real issue very quickly. So during phonation or talking, everything flips. The vocal folds adduct tightly, coming together so that air from the lungs forces them to vibrate. The vibration is what produces sound. So the key here is that airflow is no longer just passing through here. It's being regulated and converted into mechanical oscillation. Subtle adjustments in tension and position change pitch and tone. Then there's whispering, which is a bit of a weird state, but the vocal folds are mostly adducted, but there's a small posterior gap between the arytenoids, and air moves through that gap without true vocal fold vibration, which is why whispering produces sound without the same tonal quality as phonation. It's essentially turbulent airflow instead of vibration-based sound. So the pattern is straightforward. Open wide is going to be forced breathing. Closed tight is going to be phonation, or because it's going to be vibrating. And then almost closed with a tiny small gap is going to be whispering, and then just very, normal respiration is just going to be that very small little crease from top to bottom. All right. All right, so these two joints are going to be the mechanical core of voice control, and if the cartilages are the framework, these joints are going to be what actually let that framework move in a meaningful way. So the cricothyroid joint is the simpler of the two, and it just sits between the inferior horn of the thyroid cartilage and the lateral cricoid. Functionally, it behaves like a hinge, and when it moves, the thyroid cartilage tilts forward relative to the cricoid. That tilt stretches and tenses the vocal cords, increasing pitch. So anytime you think high pitch, you want to be thinking cricothyroid joint tightening the strings. It's basically tuning the instrument. So the cricoarytenoid joint is where the real complexity and clinical relevance lies. So this joint allows both rotation and gliding of the arytenoid cartilages on top of the cricoid. Because the vocal folds attach to the arytenoids, any movement here directly changes the position of the vocal cords. So rotation opens or closes the vocal folds, so abduction versus adduction, while gliding fine-tunes their position. And this is what lets you switch between breathing, speaking, whispering, and everything in between. So in practical terms, the cricothyroid joint controls tension or pitch, while cricoarytenoid joint controls position, which is open versus closed airway. Okay, one tunes the sound and the other is going to decide whether the sound or even air can pass at all. All right, and so this is where everything is going to come together here. So these muscles are going to be what actually move the vocal folds. So this is the layer that explains breathing, speaking, airway protection, and the most clinical vocal cord problems. So starting with the big picture rule, almost all intrinsic laryngeal muscles are innervated by the recurrent laryngeal nerve, except one, which is the cricothyroid, which is innervated by the external branch of the superior laryngeal nerve. So that exception is very commonly tested. Functionally, it's easiest to organize these muscles by what they do to the rima glottidis. The adductors close the vocal cords. The lateral cricoarytenoids pull the vocal processes medially, which is the main movement for bringing the vocal folds together. The transverse and oblique arytenoids pull the arytenoids toward each other, closing the posterior part of the glottis. Together, these muscles completely close the airway at the level of the vocal folds, critical for phonation and also for protecting the airway during swallowing. Then there's the only true abductor, the posterior cricoarytenoid, and it's extremely important. It rotates the arytenoids laterally, opening the vocal folds and allowing air to pass. This is the only muscle that opens the airway at the vocal cord level, which is why bilateral damage to the recurrent laryngeal nerve is super dangerous. If this muscle doesn't work, the cords can't abduct and the airway starts to narrow. Next layer is about tension control, which determines pitch. The cricothyroid tilts the thyroid cartilage forward, stretching and lengthening the vocal ligaments, and this is going to increase your pitch. Since it's the only muscle not innervated by the recurrent laryngeal nerve, injury to the external laryngeal nerve is going to lead to that loss of high pitch rather than complete voice loss. Opposing that is the thyroarytenoid, which shortens and relaxes the vocal folds, and within it sits the vocalis muscle, which allows for a very fine local adjustment and tension. And this is what lets you subtly modulate tone rather than just switching between tight or loose. So the clean functional map is going to look like this. Adductors are going to close your cords for phonation or protection. Posterior cricoarytenoid is going to be the only guy that's going to be opening your vocal folds, and that's going to be for breathing. Then you got your cricothyroids, which are going to be tensing the cords, and that's going to be for your high-pitched. And then you have your thyroarytenoid and vocalis muscle, which is going to relax and fine-tune. So it's going to be your low pitch and precision. So again, recurrent laryngeal nerve injury, is going to be cords can't move properly, so you're going to get voice and airway issues. And then external laryngeal nerve injury is going to be voice is still present, but you can't hit your high pitch. Okay? All right, so this slide is tying together vascular supply and, more importantly, innervation patterns. And the key idea you need to lock in is that the larynx is split into two functional regions, right? We have that supraglottic and the infraglottic, and they behave differently neurologically. So start with the nerves, because that's where most of these test questions come from. Everything comes off of vagus nerve, cranial nerve 10, but it divides into two major branches with distinct roles. So you have the superior laryngeal nerve, which is going to split into the internal and external branch, and then the internal branch of the superior laryngeal nerve is going to provide sensory innervation above the vocal cords, or to that supraglottic region. This is what lets you detect something like food or liquid hitting the airway and triggers protective reflexes. The external branch is motor, but it only innervates one muscle, the cricothyroid, which controls pitch by tensing those vocal cords. Below the vocal cords, everything is handled by the recurrent laryngeal nerve, which becomes the inferior laryngeal nerve once it enters the larynx. This nerve supplies all other intrinsic laryngeal muscles and provides sensory innervation below the vocal cords, or the infraglottic region. So a simple way to frame it would be above the cords is going to be your internal superior laryngeal artery or vein, nerve. Oh my gosh. And then below, you're going to have below in that infraglottic region and almost all the motor stuff, it's going to be the recurrent laryngeal nerve. So clinically, this split matters a lot. If you lose the internal superior laryngeal nerve, patients can't feel aspiration well. And that's dangerous because they may not cough. If you lose the recurrent laryngeal nerve, you lose most vocal cord movement, leading to that hoarseness and airway problems. The blood supply mirrors this organization. The superior laryngeal artery from the superior thyroid artery supplies the upper larynx, while the inferior laryngeal artery, which is a branch of the inferior thyroid artery, supplies the lower portion. And venous drainage follows the same pattern, draining into the corresponding thyroid veins. So the clean framework here is going to be vagus, which is going to split into that superior versus recurrent. And then you're going to have the superior, which is going to be above the cords, sensory, and cricothyroid. And then you're going to have the recurrent, which is going to be the below the cords, and it will be sensory, and it's going to go to all other muscles. All right, so lymphatic drainage of the larynx follows the same split as the vocal cords logics. So basically, the key idea is that the lymphatics are going to be divided into superior, above the vocal folds, and inferior pathways, right? And they drain into different levels of the deep cervical chain. So the superior epiglottic region drains into the superior deep cervical lymph nodes, and this includes structures above the vocal folds, especially the supraglottic larynx. These lymphatics are relatively rich and interconnected, which is why supraglottic cancers tend to spread early and often bilaterally. There's lots of lymphatic communication up here. In contrast, the inferior epiglottic region drains into the inferior deep cervical lymph nodes, often via pretracheal and paratracheal nodes first. This corresponds to the infraglottic region. And so the lymphatic network here is more limited compared to the supraglottic region. So infraglottic tumors tend to spread later and often follow a more predictable downward pattern. So above the cords is going to be your superior deep cervical lymph nodes, and below the cords, you're going to have your inferior deep cervical lymph nodes. All right, so the larynx is basically, again, split into three functional nerve territories, and everything here fits into that framework. First is going to be the external laryngeal nerve, branch of cranial nerve 10 via the superior laryngeal portion, and it is purely motor, SVE, and it's going to go to a very specific target, that cricothyroid muscle. It may also give some contribution to the inferior constrictor, but clinically, the only one thing you're really needing to lock in here is cricothyroid, which does pitch control, controlled by the external laryngeal nerve. If this nerve is injured, the patient can still speak, but they lose that ability to tense the vocal cords, so their voice becomes monotone and low-pitched. Next, in the internal laryngeal nerve is the sensory powerhouse above the vocal cords. It carries GVA, so general sensation, SVA, taste from the epiglottis region, and some parasympathetic fibers. It enters through the thyroid membrane and supplies the supraglottic larynx. This is the nerve tied to the clinical correlation here. If something like a fish bone gets stuck in that piriform recess, this nerve is at risk for damage. And damage here means loss of sensation above the cords, impaired cough reflex, and higher aspiration risk. So then you have the inferior laryngeal nerve, which is just the recurrent laryngeal nerve after it enters the larynx. Okay, so the nerve does almost everything else. It's motor to all intrinsic laryngeal muscles except the cricothyroid, and also provides sensation below the vocal cords. So if this nerve is injured, you get hoarseness or even airway issues, depending on whether the injury is unilateral or bilateral. So this is one of those ones that surgeons really like to worry about during thyroid surgery. So above the vocal cords, you're going to have that internal laryngeal, which is going to be sensation. Below the vocal cords, you're going to have the inferior laryngeal, okay, and that will be also known as the recurrent laryngeal, and that will be your sensation and motor. And then finally, you have your external laryngeal, which will be pitch control, and that's going to also only innervate the cricothyroid because that's what does pitch. So finally, again, the clinical correlation, highlighting it. So during procedures like intubation, you can block the internal laryngeal nerve at the thyrohyoid membrane, which removes supraglottic sensation and prevents that cough reflex, making airway instrumentation a lot easier. So if you just remember that internal laryngeal does sensation above, recurrent does everything else, and then external is just pitch with that cricothyroid, that's a pretty good place to be. All right, so this slide is pretty dense, but the pterygopalatine fossa is pretty predictable if you think of it as a neurovascular distribution center sitting just deep in your face. So you want to start with the big picture. The pterygopalatine fossa is where V2 or maxillary nerve and the pterygopalatine ganglion hang out and redistribute fibers. It's basically a relay station that sends branches to the nose, palate, orbit, and pharynx. If something passes through here, it's probably on its way to one of those regions. Now, anchoring it to anatomy, the space sits posterior to the maxilla and anterior to the pterygoid plates of the sphenoid bone, which explains why all these canals and foramina connect through it. So the roof is the sphenoid bone, which matters less clinically, but the boundaries matter because they tell you what goes in and what goes out. So the lateral boundary, the pterygomaxillary fissure, is your entry point for the infratemporal fossa, and that's how the maxillary artery basically gets into the space. So you want to be thinking blood supply enters laterally. Okay. The medial wall is the palatine bone, and this is where the sphenopalatine foramen sits. That's your route into the nasal cavity. So anything going into the nasal septum or lateral wall, you want to be thinking nasopalatine nerve and sphenopalatine vessels, which are going to be passing medially. Posteriorly is where things get pretty high yield, and because you got three key pipes here coming into this fossa. You got the foramen rotundum, which is where your V2 or maxillary branch of trigem enters. Then you're going to have your pterygoid canal, which is going to be nerve of the pterygoid canal, and that's going to be parasympathetics from facial nerve hitchhiking and providing also sympathetics. Then you're going to have pharyngeal canal, and that's going to be a small neurovascular supply to the nasopharynx. So posterior is going to be just all inputs, especially nerve traffic coming through. Anteriorly, the fossa communicates with the orbit via the inferior orbital fissure, sending out the infraorbital nerve and zygomatic nerve. So you want to be thinking anterior is the orbit. Inferiorly, everything funnels down into the palatine canal, carrying the greater and lesser palatine nerves and descending palatine artery to the palate. So if you just remember inferior palate, which kind of makes sense to where this sits anatomically, it's not too bad. So again, just putting it all in one space here. Posterior is going to be things entering, so V2, autonomics. Medial is going to be stuff going to the nose. Anterior is stuff going to your eyes. Inferior is going to the palate. And lateral is going to be artery entry. You want to be thinking maxillary artery for that lateral. And the pterygopalatine ganglion is going to be sitting right in the middle and is just redistributing parasympathetics from facial nerve to the glands in all these regions. So if they test this, if this comes up, it's not usually list every boundary. It's more so like, where does V2 pass? And that's going to be foramen rotundum. How does parasympathetics reach the nasal glands? And that's going to be through the pterygoid canal to the ganglion, then finally its branches. What artery supplies the posterior nasal cavity? And that's going to be the sphenopalatine artery through the medial wall. And I'll break all these down later, but just giving you an idea of where this is going. So this is just your big general overview of this space. All right, and remember way back when we were covering the branches of the maxillary artery, here are our last 6 here. And this slide is basically like the branches of the maxillary artery in the pterygopalatine fossa, which is convenient because this branch of the maxillary artery is called the pterygopalatine branch, okay? So think of it like this. Once the maxillary artery enters the pterygopalatine fossa, it starts fanning out to the teeth, face, palate, nose, and pharynx, and each branch is going to be tied to one of those destinations. So start with the posterior superior alveolar artery. This one goes straight for those maxillary molars. So if they ask about blood supply to the posterior upper teeth, this is your answer. It runs along the posterior maxilla and feeds the dental structures. The infraorbital artery continues forward into the orbit and comes out onto the face, and this one supplies the midface, think lower eyelid, upper lid, and also contributes to the anterior maxillary teeth via smaller alveolar branches. So this is your front of the face and some of the teeth, okay? Next is the descending palatine artery, which drops down through that palatine canal that we touched on last slide and splits into the greater and lesser palatine arteries. These supply the hard and soft palate, respectively. So anytime you see palate blood supply, this is where they're getting it. The artery of the pterygoid canal is smaller and is a little bit more niche, but it runs backward towards the sphenoid sinus and the upper pharynx. So following the same pathway of as the nerve of the pterygoid canal, it's not usually high yield, but it shows up in anatomy stuff, so good to know. The pharyngeal artery is also small and goes to the nasopharynx, and it's going to be contributing to its vascular supply there. So finally, the sphenopalatine artery is a big clinical one, and this is essentially the terminal branch of the maxillary artery and the main blood supply to the nasal cavity. It enters through the sphenopalatine foramen. So if you hear posterior epistaxis, this is the vessel involved. It's harder to control and more clinically significant than anterior nosebleeds. So the clean mental map is here. So teeth, the posterior teeth are going to be that posterior superior alveolar. The midface and anterior teeth are going to be your infraorbital. Palate is going to be your descending palatine. Nasal cavity is going to be your sphenopalatine. Nasopharynx is going to be your pharyngeal, and deep sinus region is going to be the artery of the pterygoid canal. And remember, sphenopalatine is the pretty high yield one to focus on here. All right, so again, this looks like a brutal slide, but again, course explains the branches. All right, so if you follow V2 step by step, the branches organize themselves. All right, so start at the origin, the maxillary nerve, V2. It's going to leave the trigeminal ganglion and exit the skull through the foramen rotundum, landing directly in the pterygopalatine fossa. That location is key because this is where it meets the pterygopalatine ganglion and becomes a distribution highway for both sensory fibers and hitchhiking autonomics. At this level, the first important idea is that V2 itself is purely sensory, GSA, but it carries parasympathetics and sympathetics to targets like the nasal mucosa and lacrimal gland. It's not generating those fibers, it's just the delivery guy, right? So once inside the fossa, small ganglionic branches connect V2 to the pterygopalatine ganglion, and from there, multiple branches peel off depending on destination. If fibers are heading posteriorly or medially toward the nasal cavity, you get branches like the nasopalatine nerve and other nasal nerve. These pass through the sphenopalatine foramen and supply the septum and lateral nasal walls. That's your nose pathway. If fibers go inferiorly, they travel through the palatine canals as the greater and lesser palatine nerves, similar to our arteries, and they're going to be supplying the hard and soft palate. That's the roof of your mouth pathway. If the fibers go posteriorly through the pterygoid canal, they join the nerve of the pterygoid canal, which carries autonomics, all right? So that's going to be parasympathetics from cranial nerve 7 and sympathetics. This is how secretomotor fibers reach glands in the nasal cavity and palate. Now, shift anteriorly, the main focus of V2 becomes the infraorbital nerve, which enters the orbit via the infraorbital fissure, and it's going to run in the infraorbital canal and exit onto the face. Along the way, it gives off anterior and middle superior alveolar branches to the maxillary teeth that emerge to supply the midface, so lower eyelids, upper lid, and lateral nose. Before it becomes infraorbital, V2 also gives off a zygomatic nerve, which enters the orbit and splits into zygomaticotemporal and zygomaticofacial branches. The zygomaticotemporal branches is especially important because it carries parasympathetics to the lacrimal gland, okay? And this is going to be via that connection to the lacrimal nerve from V1, okay? So that is a very classic test point there because of the weird overlap between V1 and V2. The posterior superior alveolar nerves branch off earlier and go directly to the maxillary molars. So now you're covered all the upper teeth, okay? Posterior, PSA, middle, anterior via infraorbital branches, right? The smaller branches like the pharyngeal nerve just head to the nasopharynx, rounding out the distribution, okay? So Zooming out very, very quick, we have V2. It's going to enter that foramen rotundum. It's going to land in the pterygopalatine fossa. Its medial branches are going to be going to the nose. So that's going to be your nasopalatine and your nasal nerves. You're going to have your inferior branches, which are going to be going to that palate, greater and lesser palatine. Then you're going to have the posterior branch, which is going to be autonomics, and that's going to be nerve of the pterygoid canal. And then you're going to have the anterior continuation, which will be the infraorbital, and that's going to be the face and anterior teeth. And then you'll have your lateral and orbital branch, which will go to the zygomatic, and that will be your lacrimal gland pathway. And then your posterior teeth are going to be your posterior superior alveolar. All right, so this is one of the highest yield autonomic slides in the head and neck, and the trick is to follow the parasympathetic pathway cleanly from start to finish. So the pterygopalatine ganglion itself is just a relay station for parasympathetics. It doesn't generate the signal. It simply just houses the postganglionic neuron cell bodies. So everything starts with actually the facial nerve, specifically the preganglionic parasympathetic fibers that originate from the superior salivatory nucleus, okay? And they're going to travel as the greater petrosal nerve. That nerve is then going to join with the deep petrosal, the sympathetics, to form the nerve of the pterygoid canal. And this is what actually enters the pterygopalatine fossa. Once those fibers reach the pterygopalatine ganglion, the parasympathetics synapse, that's the key event here. So preganglionic, synapse, postganglionic. After that, the ganglion sends postganglionic parasympathetics fibers out by hitchhiking on V2 branches, so your maxillary branch of trigem. And V2, again, is just the delivery route, okay? So from there, the fibers are going to distribute to two major targets. First, the nasal cavity and palate glands. These fibers travel directly with V2 branches, like the nasopalatine and palatine nerves, to stimulate mucus secretion. Second, the lacrimal gland, which is slightly more complicated, but the postganglionic fibers are going to go to the pterygopalatine ganglion, which is then going to join up with V2. Then it's going to split off to the zygomatic nerve, and then it's going to join up with the communicating branch to the lacrimal nerve from V1, and it's finally going to hit the lacrimal gland. So that pathway gets tested constantly because, again, that V2 to V1 division, okay? It's a little weird, but just remember it, all right? Because it will definitely show up on the exam. So the clinical side becomes more straightforward. If you disrupt the ganglion or its incoming fibers, you're going to get lacrimal gland dysfunction, so you're going to have a dry eye. A nasal gland dysfunction, you'll have dry or irritated nasal passages and increased infection risk. So if you need a clean way to write it out, cranial nerve 7 is going to send nerves to the greater petrosal, then greater petrosal will become nerve of the pterygoid canal, and then from nerve of the pterygoid canal, it's going to synapse in the pterygopalatine ganglion, and from there, its fibers are going to hitchhike on V2, and those are going to distribute to glands. If you remember that sequence, you can you'll be able to rebuild it pretty quickly on exam day. So don't forget that pterygopalatine ganglion is going to be parasympathetics to tears and mucus delivered by V2, okay? That will eventually join up with that the lacrimal nerve of V1. All right, so this slide is just the sympathetic counterpart to everything we just learned about the pterygopalatine ganglion, and it's much simpler when you separate one key idea, which is these sympathetic fibers do not synapse in the pterygopalatine ganglion. So starting at the beginning, sympathetics to the head originate from the preganglionic neurons in T1 and T4, like most of our sympathetics in our head, which ascend the sympathetic chain and synapse in, you guessed it, the superior cervical ganglion. That's the only synapse that matters in this pathway. From there, you have postganglionic sympathetic fibers, and those fibers wrap around the internal carotid artery, forming the internal carotid plexus. This is how they enter the skull. A branch of that plexus becomes the deep petrosal nerve. So when you see deep petrosal, just think postganglionic sympathetics riding along the internal carotid artery into the skull. Now, this is where it connects to what you already know. The deep petrosal nerve joins the greater petrosal nerve, okay, which are going to be, again, those parasympathetics from cranial nerve 7. And together, they form the nerve of the pterygoid canal, okay? That combined nerve travels to the pterygopalatine ganglion, but here's the key distinction. Parasympathetic synapse in the ganglion, whereas sympathetics are just passing straight through without synapsing. So after that, the sympathetic fibers are going to hitchhike on V2 branches, just like the parasympathetics did, and get distributed to the same regions like the nasal mucosa, the palate, and the lacrimal gland. So functionally, these sympathetics are doing vasoconstriction and modulation of gland secretion and not directly causing secretion, right? These are sympathetics. So if parasympathetics are turn the faucet on, sympathetics are going to be more like adjust the pressure. So the clean pathway is T1 to T4, superior cervical ganglion, internal carotid plexus, deep petrosal nerve. It's going to join the greater petrosal nerve. Then it will become the nerve of the pterygoid canal. It's going to pass through the pterygopalatine ganglion, but it will not synapse there. It will distribute via V2 branches. Okay, so deep petrosal, postganglionic sympathetics that join with facial fibers that never synapse again. All right, so this slide is really about separating structure versus function versus innervation, and because once you organize those three, the palate becomes pretty predictable. So start with structure. The hard palate is just bone, and it follows a simple rule. The anterior 3/4 are going to be maxilla. The posterior 1/4 is going to be the palatine bone. That's mostly a landmark question, and that will just be either a way to tie it into blood supply or just a one-off, do you know it? Right behind that is the tonsillar fossa, which is clinically important because cranial nerve 9, glossopharyngeal nerve, runs there along with the tonsillar vessels. That's why tonsillectomies can be painful and risky. This nerve provides sensation and contributions to the gag reflex. Now shift to the soft palate, which is where the real physiology lies. Almost all of these muscles come from pharyngeal arch 4 and are innervated by cranial nerve 10, with one exception that they love to test. The exception is going to be tensor veli palatini, which comes from arch 1, okay, and is innervated by cranial nerve V3, and its job is mechanical. It tenses the soft palate, acting through that pulley-like system around the pterygoid hamulus. Everything else is going to be vagus. So levator veli palatini is the main lifter. It elevates the soft palate to close off the nasopharynx during swallowing, preventing food from going up the nose. Palatopharyngeus helps us with swallowing by pulling the pharynx upward. Palatoglossus coordinates the tongue and palate, helping control the oral cavity during swallowing. And uvula muscle assists in elevating and sealing the soft palate. So functionally, the soft palate is acting like a movable door that seals the nasal cavity during swallowing because we don't want food in our nose. So now the clinical piece ties it together. If you lesion cranial nerve 10, you lose motor function to most of these muscles on one side. That intact side is still pulling upward, so the uvula starts to deviate away from the lesion toward the normal side. And that's a classic exam finding there. So again, structure, hard palate is just bone, and then you have your tonsillar fossa, which has cranial nerve 9 in there. Motor is going to be mainly cranial nerve 10, except tensor veli palatini, which is cranial nerve V3, okay, or trigem. Or the mandibular branch of trigem, right? Then functionally, it's going to be to close the nasopharynx during swallowing, and then a lesion will cause that uvula to deviate away from the cranial nerve 10 lesion, okay? All right, and this slide is really going to be testing whether you can separate sensory innervation from motor and then map everything cleanly onto V2 distribution pathways, okay? So start with the big rule. All general sensation of the palate is going to be V2 or maxillary nerve. Not cranial nerve 10, not cranial nerve 9. This is a pure trigeminal sensory territory. What V2 is doing here is acting like a delivery route. It's just carrying not only sensation, but also autonomic fibers coming from the pterygopalatine ganglion. So now break it down spatially. The anterior hard palate is supplied by the nasopalatine nerve. This nerve comes from the nasal cavity, travels through the incisive canal, and then spreads across the front portion of the palate. If you can imagine airflow entering the nose and wrapping down to the palate, that's essentially its path, right? So the majority of the hard palate, especially the posterior and lateral regions, is handled by the greater palatine nerve. And it's going to descend vertically through the greater palatine canal and then fan out anteriorly along the palate. And that's going to be your main coverage, all right? The soft palate and the very posterior edge are supplied by the lesser palatine nerves, which comes through the lesser palatine foramina, and you want to be thinking of it as finishing the job of the greater palatine nerve, okay? So now, layer in blood supply. It's going to mirror the nerves very closely. The greater palatine artery does most of the work for the palate, especially anteriorly, while lesser palatine arteries, guess what? Supply the posterior and soft palate. So same idea, big vessel, big territory, small vessel, small territory. The subtle but high-yield concept here is that even though V2 is sensory, it also is the carrier for those autonomics coming from the pterygopalatine ganglion, which again is that facial pathway. So when the glands in the palate secrete mucus, that signal technically originated from the facial nerve parasympathetics, but it's riding along V2 branches to get there. So don't forget, V2 is going to be sensation in that middle face and the bridge of your nose. And the anterior hard palate is going to be your nasopalatine nerve through the incisive canal. The most of the palate is going to be your greater palatine nerve. Posterior and soft palate will be your lesser palatine nerve. Arteries are going to be following that same distribution, and autonomics are going to be hitchhiking on V2 from cranial nerve 7. I know I've said that a million times by now, but seriously, this will show up on the exam. All right, so think of the oral cavity as having two compartments separated by teeth. It's not just one big space, right? The vestibule is the outer space between the lips and the cheek of the teeth. Not of the teeth, between the lips, cheeks, and the teeth. And that's where food initially sits when you're chewing, like a squirrel storing little snacks, or a chipmunk. Then once food moves inside the teeth, you're in the oral cavity proper, which is the functional workspace where the tongue actually manipulates the bolus. Now anchor the boundaries, right? Because this loves to get tested. So the roof is the palate. Boundaries just like to get tested. Not this specifically. I'm just saying boundaries. You don't want to get blindsided by it on the exam. So the roof is going to be the palate. Hard anteriorly, soft posteriorly. The floor is going to be is just the floor of the mouth, mainly the mylohyoid region with the tongue sitting on top. The posterior boundary is the fauces, which is the gateway to the oropharynx, basically the exit door of the oral cavity. The small, little clinical tie-in here is that the parotid duct opening, or it surrounds the parotid duct opening, and it empties into the vestibule, not the oral cavity proper, and specifically opposite the second upper molar. If they ask where saliva from parotid enters, it's not under the tongue. That's submandibular or sublingual territory. Parotid, remember, it's a little higher, so it's going to be that lateral cheek into the vestibule, and it will be close to that second maxillary molar. So there you go. All right, so again, this is one of those slides that's going to be testing on separating motor, sensory, and lymph, clearly. So we're going to start with the muscle, right? So the lips are controlled by muscles of facial expression, so all movement, so smiling, puckering, closing the mouth is going to be cranial nerve 7, right? Facial expression. If the lips don't move, you want to be thinking facial nerve issues, right? So now, switching to sensation, that's completely different. The lips follow the trigeminal map. So the upper lip is going to be V2, the maxillary division, and the lower lip is going to be V3, the mandibular division. So a clean horizontal split across the mouth. Same applies to the teeth. The upper teeth are going to be V2, lower teeth are going to be V3. If they ask about dental pain localization, that's kind of what they're probing at. Lymphatics are where people like to slip up here. So the key exception is the midline lower lip, which drains to the submental nodes. Everything else, the lateral lip and essentially all of the upper lip, goes to the submandibular nodes. So the rule is midline lower is going to be your submental, and everything else will be submandibular. Clinically, this matters for things like lip cancers or infections when you track the spread based on drainage patterns. All right, so just remember with lips, movement is going to be your facial. Sensation is going to be V2 for the upper and V3 for the lower. Teeth are going to follow that same pattern of V2 upper, V3 lower. And lymph, the midline lower portion of the lips will be the submental region, which makes sense because of that mentalis muscle being right over your chin. And then the rest will be your submandibular. Okay, so starting with the big split here. So intrinsic muscles change shape. They let the tongue curl, flatten, elongate, or narrow. They don't move it around. They just fine-tune it. Think of them like precision tools. Intrinsics are precision. Then extrinsic muscles change position. They actually move the tongue in space, which is what matters for swallowing, speech, and airway control. Now, running through the intrinsic muscles in a way that actually sticks, you have the genioglossus being the most important here. It protrudes the tongue. This is the one that keeps the airway open. If you lose it, the tongue will fall back. The hyoglossus depresses the tongue. It pulls it down. The styloglossus retracts and elevates it, and it pulls it back and up. And then the oddball here is palatoglossus, which is going to elevate the tongue. But more importantly, it's the only one that does not follow the hypoglossal rule. So the highest yield thing to kind of take away from this is innervation here, all right? So all the tongue muscles are going to be hypoglossal muscle except for palatoglossus. Palatoglossus is cranial nerve 10, which is vagus, right? So if you remember anything else, just remember that exception. So the clinical piece here is when you have a cranial nerve 12 lower motor lesion, the tongue deviates towards the side of the lesion when you stick it out. The reason is mechanical. The intact genioglossus on the opposite side pushes harder, so the tongue gets shoved towards the weaker side. So if the tongue deviates to the right hypoglossal region. So don't forget, intrinsic is going to be shape. Extrinsic will be movement. Cranial nerve 12 basically does the majority of the tongue, but palatoglossus is the one guy that is innervated by cranial nerve 10, and tongue deviation will be toward the lesion. All right, so this is one of the highest yield things here, and it's pretty simple, but just including it here for that repetition and just consolidation. So starting with the key idea, the tongue is split twice by location and function, so general versus taste. For the anterior 2/3, the functions are split between two nerves. General sensation, like touch, pain, temperature, is carried by V3 via the lingual nerve. That's trigeminal doing what trigeminal always does, which is somatic sensation. But taste from that region is not trigem. It's going to be cranial nerve 7 via that chorda tympani, which is going to be hitchhiking along the lingual nerve to get there. So one region, two nerves, two different modalities. The posterior 1/3 simplifies things. Both general sensation and taste are handled by cranial nerve 9. There's no splitting here. Cranial nerve 9 does everything for that region. Finally, the small but testable piece is the epiglottic region. Both general sensation and taste here are handled by cranial nerve 10 or vagus. It's a small territory, but it shows up in questions because it's easy to forget. So again, easy way to put it down, anterior 2/3, general is going to be from V3, taste is going to be 7 from chorda tympani. The posterior 1/3 of the tongue will be general and taste coming from 9, and the epiglottis will be general and taste coming from cranial nerve 10. All right, so this is about understanding Waldeyer's ring as a defensive perimeter, okay? So picture it as a circular band of lymphoid tissue sitting at the entrance of both the respiratory and GI tracts. Everything you inhale or swallow has to pass through this ring, so it's your first immune checkpoint. Now, place the tonsils spatially, right? So at the roof of the nasopharynx, you have the pharyngeal tonsils, or the adenoids. And this one is clinically important because when it enlarges, it can block your airway posteriorly, especially in kids, leading to mouth breathing and snoring. Near the openings of the auditory tubes, you have the tubal tonsils. These are small but high yield. If they enlarge, they can block the auditory tube, leading to middle ear problems like otitis media. Move down into the oropharynx, and between the fascial pillars and the palatine tonsils, between the fascial pillars is where the palatine tonsils sit. And the ones people usually mean when they say tonsils are these guys. So these are the most commonly inflamed ones in tonsillitis, and the ones that are removed in a tonsillectomy. Then at the base of the tongue, you have the lingual tonsils, which are less talked about, but complete the ring inferiorly. So the ring goes nasopharynx, pharyngeal plus tubal tonsils. And then it goes oropharynx, which is going to be your palatine tonsils. And then finally, the tongue base, which will be your lingual tonsils. Function-wise, all of these are doing the same job. These are all sampling antigens and initiating immune responses, okay? So, and again, the clinical correlations here are going to be your adenoid enlargement could lead to airway obstruction. Your tubal tonsils can lead to ear issues like otitis media because they will block that auditory tube. And then your palatine tonsils can cause infection, abscesses, and, that tonsillectomy relevance there. All right, so we are kind of touching on that week 1 neuro content, but I'm just reinforcing here because it got brought up in week 3. But we're going to meet our friends, the suprahyoids again, right? Our suprastars, okay? So the suprahyoid muscles are best understood as a functional group that's going to coordinate movement between the mandible, hyoid, and larynx, and their primary role is going to be to elevate that hyoid bone during swallowing, which in turn lifts the larynx and helps protect the airway. So if the hyoid stabilizes the head, these same muscles act to depress the mandible and open the mouth. So mechanically, they function as a bridge between swallowing and jaw movement, depending on what structure is fixed. What makes this group a high-yield group is not just their function, but their innervation pattern. But it all just kind of follows embryology, okay? So the anterior floor of the mouth muscles, like the mylohyoid and the anterior belly of digastric, are going to be innervated by V3 via the nerve to mylohyoid, reflecting their origin from the first pharyngeal arch, right? Remember, first arch is going to be innervated by trigem. In contrast, the posterior belly of digastric and the stylohyoid are going to be innervated by the cranial nerve 7, okay, facial, consistent with the second arch derivatives. And then finally, we have geniohyoid, which does not fit cleanly into either category because it's supplied by C1 fibers that travel with the hypoglossal nerve and the ansa cervicalis, right? Going back to weeks 1 and 2, making it that common exception that shows up in exams. So the digastric muscle is especially important because it contains both anterior and posterior bellies, each with those different innervations. And that dual innervation is a favorite testing point because it forces you to apply the pattern of embryology rather than just memorizing all those nerves, right? So if you remember that the anterior structures align with V3 and the posterior structures align with facial nerve, and that geniohyoid is that C1 exception, you can reconstruct the entire group without relying on just memorizing all of it. So clinically, these muscles contribute to the initial phase of swallowing, and dysfunction can present as a difficulty initiating swallowing or coordinating jaw opening because their innervation is split across different cranial nerves. Lesions can produce selective deficits, which is why understanding this pattern is more useful than memorizing individual muscles in isolation. All right, so the submandibular region is one of those areas where the anatomy is deceptively simple on paper, but clinically dense because of what is running through it. So you should picture it as a triangle space tucked. I know we love triangles in anatomy, but I know, one more, don't worry. So it is a triangle space tucked just under the mandible, bounded superiorly by the mandible itself and inferiorly by the digastric muscles. That framing matters because it helps you orient pretty much everything else in this picture. So if you know where the mandible and digastric sit, you can reconstruct this region. So what actually lives in the space is what makes it high yield. The submandibular gland is the central structure, essentially occupying the triangle like a resident tenant. Right? Wrapped around and coursing through this area is the facial artery, which takes a characteristic tortuous path as it hooks around the inferior border of the mandible to enter the face. That relationship is clinically important because the artery is palpable here and also vulnerable to trauma or injury. Running nearby is the hypoglossal nerve, cranial nerve 12, which is quietly critical because it supplies the intrinsic and most it supplies all intrinsic and most extrinsic tongue muscles. If that nerve is injured in this region, that deficit won't show up as a neck problem. It shows up as a tongue deviation, which throw a lot of people off if they're not thinking anatomically. A useful way to think about this region is a crossroads between the face, oral cavity, and neck. The gland handles saliva production, the facial artery brings in vascular supply to the face, and cranial nerve 12 provides motor control to the tongue. So even though the slide lists only a few structures, each one has outsized clinical consequences, right? So that's why this region shows up in questions about salivary gland pathology, surgical landmarks, and nerve injury patterns, because a small space is doing a lot of work here. Okay, and this slide is really just about the autonomic pathways to salivary glands, and we've covered these a couple times, surrounding other topics like, different fossas that they're associated with, but just to put them in one spot, here we go. So starting with the parotid, because it's the odd one out, it's the largest salivary gland and it runs entirely off of cranial nerve 9, glossopharyngeal, for its parasympathetic supply. The pathway looks long, but it's actually very structured. So cranial nerve 9 gives off the tympanic nerve, which becomes the lesser petrosal nerve, then synapses in the otic ganglion. After that, the postganglionic fibers hitchhike on V3 via the auriculotemporal nerve to reach the gland. The key idea is that cranial nerve 9 does not go directly to the gland. It always synapses in the otic ganglion first, okay? Then uses V3 as a delivery route. Now compare that to the submandibular and sublingual glands, which share the same setup and are both controlled by the facial nerve, or cranial nerve 7. Instead of the tympanic route, cranial nerve 7 sends fibers through the chorda tympani, which then joins that lingual nerve, a branch of V3, and those fibers are going to synapse in the submandibular ganglion, and from there distribute to both submandibular and sublingual glands. So again, the cranial nerve doesn't go straight to the gland. It joins V3, synapses in the ganglion, then continues. If you step back, the pattern becomes pretty clean, right? Parotid uses cranial nerve 9, otic ganglion, then V3 carrier, while submandibular and sublingual use cranial nerve 7, and they are going to go through chorda tympani and then use the lingual nerve, which is also part of V3. And then it will finally go to that submandibular ganglion. Different cranial nerves, different ganglia, but the same logic, with preganglionic fibers traveling with the cranial nerve, the synapse, then hitchhiking on trigem branch to reach the target. The gland type also matter clinically. The parotid is mostly serous, the submandibular is mixed, and the sublingual is mostly mucus. That translates to function, so watery enzyme-rich secretions versus thicker lubricating mucus. When something goes wrong, like a nerve damage or gland dysfunction, you'll see dryness patterns that reflect which pathway is affected. For example, damage to the cranial nerve 7 proximal to the chorda tympani can reduce salivation from the submandibular and sublingual glands, while a lesion affecting cranial nerve 9 pathways impacts the parotid specifically. So instead of memorizing the 3 glands separately, it's more efficiently to memorize them as part of the systems that they're a part of, right? So cranial nerve 9 for parotid, cranial nerve 7 for sublingual and submental, and both rely on, or submandibular, my bad, so sublingual, submandibular, and both rely on trigeminal branches as delivery highways after synapsing in their respective ganglia. Okay, and then finally, to wrap this video up, I just have a clinical high-yield overview of just some of the clinical correlates that popped up in the program. So just think of this as just like a buzzword guide for vignettes, okay? So start with sublingual drug absorption, right? So the key idea is that the floor of the mouth is thin and highly vascular, so drugs placed under the tongue are absorbed rapidly into the bloodstream. They drain through the lingual veins into the internal jugular vein and enter systemic circulation directly, which means they bypass first-pass metabolism in the liver. And that's why drugs like nitroglycerin are given sublingually because of its fast onset and no hepatic delay. Next is the hypoglossal nerve lesion, which is a classic localization question. A lower motor neuron lesion of hypoglossal nerve produces atrophy and fasciculations of the tongue. The high-yield move is what happens on protrusion. The tongue will deviate towards the side of the lesion. This happens because the intact contralateral genioglossus pushes unopposed, so the tongue gets pushed toward the weak side. If you remember nothing else, just remember lower motor neuron cranial nerve 12 lesion means deviating towards it, okay? The parotid gland secretion is labeled as a big test area for a reason, because the important concept is layering of the structures within the gland from superficial to deep. Facial nerve first, then retromandibular vein, then external carotid artery. The facial nerve is the most clinically important because it branches within the gland. That means parotid tumors or surgeries risk facial paralysis, even though the nerve does not innervate the gland itself. So it's just passing through, unfortunately in a very vulnerable way. Okay, so the submandibular duct and lingual nerve relationship is another classic trap here. So the lingual nerve wraps around the submandibular duct as it courses through the floor of the mouth. This creates a close anatomical relationship that matters clinically because procedures involving the duct or gland can injure the lingual nerve, leading to loss of general sensation and taste via chorda tympani fibers in the anterior 2/3 of the tongue. And then finally, tonsillar enlargement ties back to that Walder's ring, and these tonsils form a ring of tissues in the pharynx, and when enlarged, they can obstruct either airway or the auditory tube. And that's why kids with big adenoids can have breathing issues or recurrent ear infections. It's not just a throat problem, it's a space problem, right? So, if you zoom out, the pattern across the slide is consistent. Small anatomical relationships lead to predictable clinical consequences, and that's exactly how these things get tested. All right, folks, and that will do it for Neuro Week 3. Thank you guys so much for watching. As always, I hope this was helpful. I hope you were able to consolidate some knowledge you learned in class, get some good review in. Good luck on your studying. Don't burn out, right? Neuro is a long system. So keep on going. You've made it this far. You keep on pushing, all right? Thank you, as always, for stopping by MooseMed, where we take medicine by the horns, but for all intensive purposes, moose have antlers. Thank you as always, folks. I will see you next Saturday when we are doing Neuro Week 4 and 5. All right. Peace.